That is also we have seen nasopharyngitis, URTI and UTI. Herpes zoster reactivation and herpes simplex infection is very common. In my practice, rather than herpes zoster, herpes simplex, I have seen a lot of cases of herpes in reinfections. Then nausea, diarrhea, then elevated liver enzymes, hypolipidemia, increase in bilirubin and creatine phosphokinase, blood cell count, decrease in hemoglobin count, WC count and neutropenia, and some rare adverse event, thromboembolic events, non-melanoma skin cancer and solid cancer has been noticed. So it should not be given whose hemoglobin level is 8 less than 8. So that's why we should do a baseline hemoglobin level, and after giving the medicine after 1 month, if you see less than 2 or decrease of more than decrease of 2 milligram of hemoglobin, then also you should. Suppose patient was having 14, now less than 12, you should also rethink about continuing this drug. Then thromboembolic event is very important. If the patient is not mobile or non-ambulatory patients, then you should take cautions. But one advantage point of tofacitinib is there was one article in 2016 which said that it converts the white fat to brown fat. So it is a good drug to give in obese people. That is the advantage of tofacitinib. So this is the oral surveillance study compared to the safety of tofacitinib TNF inhibitors. So FDA and EMA response to oral surveillance study, like avoid in more than 65 years old, history of smoking because of the risk of thromboembolism. Because that is the life-threatening event. Other infections can be treated. Even if patient develop herpes simplex or zoster, it can be treated the normal way we treat in normal patients. But thromboembolic events are the life-threatening situations. So risk factor, history of smoking, and having a chance of history of DVT and all are real situation where you should think of stopping tofacitinib. And in our country where TB is very endemic, always we go for a screening for TB. If active TB infection is there, first we have to treat the TB in the normal way, then we can start tofa. And also throughout the treatment period, the surveillance has to be there for reactivation of occult tuberculosis. Now coming to the laboratory test. So initial screening, as I have said, age more than 65 years, smoking, use of oral contraceptive, tuberculosis, cardiovascular disease, risk of hepatitis B, C, then pregnancy lactation, risk and history of thromboembolism and blood clotting disorders, malignancy and vaccination status. All these are like where you will not start. Then baseline lab investigation, complete blood count with differential liver and kidney function test, tuberculosis test, then hepatitis B, C, baseline lipid panel, because then only you can know whether the cholesterol level or the LDL level is increasing and not, and pregnancy test where is applicable. Then after 1 month, do a CBC, LFT and KFT. After 3 months, again CBC, LFT, KFT along with the lipid panel. Then every 3 to 6 months, do a CBC, LFT and KFT. So when we compare with other drugs, it is relatively safe. That's why from the very beginning I have said, it is jack of all trades and master of some. We know the efficacy cannot be same in each and every patient, but definitely it is a very friendly drug to the patients and very safe drug from the doctor perspective. So now coming to, these are various reports, compilation of various articles where we have seen improvement of alopecia areata. So now I think we are good enough, we are having good personal experience with improvement of alopecia areata with tofacitinib. But my suggestion is never start 5 milligram, that doesn't work. If you want to get response, then always start with 5 milligram twice daily. These are some from the journals. Then in vitiligo, normal, when tofacitinib came, everyone was thinking it is meant for psoriasis. But my personal experience is it works more in alopecia areata and vitiligo rather than psoriasis. Because psoriasis, I think the dose we are giving 5 milligram twice daily is not good enough. I have given few patients 10 milligram daily, they respond very well. But again, we have to think twice or thrice before starting higher doses, because the recommendation, the FDA approval is not there for only skin psoriasis, that is for arthritis. So this is some of the vitiligo patients, and again evidence for atopic dermatitis. This works very well. Even the topicals works very well for atopic dermatitis than in other conditions. So So wherever I have given topicals, I have given for atopic dermatitis only. So I don't have experience in vitiligo because I don't think it is not a cost-effective one to start topical. So these are some evidence again for psoriasis. Again, I am not going twice daily. So to summarize, so JAK-STAT inhibitors, these are jack of all trades and master of some that we have to understand, and with practice, with our experience, we can tailor the thing where can be given because it is very safe in children. So this is a good drug. So far other immunosuppressives are concerned, and regarding I think rest of the things, all the queries we will discuss in the panel discussion. Thank you, sir, for giving me this opportunity.
Thank you, Dr. Manas, for that wonderful talk. You have covered all the aspects of jacking. And I think we are yet to come out with the correct dosage as well as the correct duration, because it's a new kid round the block. So I think we all should be, experimenting more with it and come to a scientific conclusion of what is the dose and for how long you should probably continue it on. So now.
I would like to request Dr. P.K. Srivastava, moderator, for the next panel discussion.
Can I just ask a few questions if there's time?
Okay. You can ask one.
We will discuss the questions in the panel. Okay, fine.
Let me introduce the moderator. Previous slide, please. Our moderator, Dr. Srivastava, is a consultant dermatologist, Mansi Skin and Allergy Clinic, Prayagraj. And he has been a secretary of CODFI and a member British Association of Dermatologists, member of EACD, member of EACT, and invited speaker in the international conference. And he has got a number of publications, and he has been a guest speaker at different occasions in national and national forum, and he has written also books in post-graduation dermatology.
Thank you, Chairperson, for the nice introductions. Now let's discuss the practical aspect of this so far with various diseases, especially the immune-mediated inflammatory disorders. My only panelist at the dais is Dr. Manas Ranjan Kohan, and whole of the audience is my panel. I've included my panel, whole of the audience, so everybody can respond and give their valuable inputs in that. Now this, as has already been discussed, that this JAK pathway is used in many IMIDs, that is in immune-mediated inflammatory dermatosis, and that depends upon the JAK-STAT signaling, and JAK inhibitors are the useful in treating various IMIDs. So my first question is directly to the including chairpersons even. Which of the conditions are you using these JAK inhibitors, and what is the overall experience? Even the audience, from the audience can have their inputs. Manas.
Sir, I have already told, so I am not giving that much in psoriasis because I am not getting any cost effectiveness in psoriasis. But definitely, I have given lot of patients in alopecia areata and vitiligo. They respond very well. So mostly I give in vitiligo.
Anybody from the audience?
Just there are 4 major treatments now. It has been approved for atopic dermatitis. Number 1. Number 2 is alopecia areata.
Right.
Number 3, vitiligo.
Okay.
And psoriasis.
Right.
But there was a recent paper in which they say that there is a comparative study in a generalized psoriasis in which they found it safer by using topical, whole body topical tofacitinib 2% compared to oral 5 milligram BD.
Right.
There has been cases where alopecia areata they have treated for 2 years, it didn't respond, and they had to add injection tricot, and then they responded in children and commonwealth. And some people have written that you increase the dose from 5 milligram BD to 10 milligram BD, response is there, but most of it, they found it will not respond. Now the question is, when would you consider that tofacitinib is not working, and what would you recommend if the tofacitinib is not working?
We will come to that, sir. Thank you for your input, sir. So these are the, the 4 important indications which most of us are using it. And
can I just add that Dr. Manas just mentioned that tofacitinib can be given to children more than 2 years of age, and the dose that you spoke about was 3.25 if it's between 10 and 20, and 20 to 40 you give 4 milligrams.
Yeah.
But the formulation that is available, at least in India, is only a 5 milligram tablet. So how do you do that?
So actually that's why this dose is given, because it is available in syrup formulation of the originator molecule from Pfizer. So that is 1 milligram per ml, that syrup is available. So that's why they have that recommendation come from the study for that syrup. But in India, it is not available, but very soon it will be available, already in the pipeline. Tofacitinib syrup will be available very soon.
So we are going to get the suspensions also very soon.
Can I just add one more thing?
Yeah.
That my question to Dr. Manas is that when do you decide in which cases of vitiligo do you choose to give tofacitinib?
So, madam, we will come to that now in the panel discussion. We have a question regarding that. Right. So let's start with the first case. This is a case of alopecia areata. This 90-year-old female, loss of hair on the scalp for the last 10 months, no other complaints, came to my clinic for the last year. All conventional therapies including the immunosuppressants, were to no purpose. Lab parameters were normal. Now, these are the photographs of the patients. Now, how will you proceed, or how this case should be managed? Anyone from the audience or from the panel?
Right now,
So-
there are give toppers.
So I'll think of cyclosporin or tofacitinib, as madam has told, but in this child, I think because it is less than, the weight will be very less, so breaking tofacitinib, it doesn't give that much good result.
She has already been on cyclosporin, but very few, very less amount of relief was there, and the parents had discontinued that, and they were worried about because she is a female.
Actually, sir, truly speaking, in alopecia areata, we don't know which patient will improve with which medicine. I think sometimes it is God's grace only. So we just go on trying one by one, and because there is no way how to choose whether this patient will respond to steroid, this patient will respond to.
She has tried all the medication available under before this.
Sir, I will think of eczema.
But all of was no use.
Can I?
Yeah, please.
So I use frequently oral tofacitinib, but
Yeah.
however, in this patient, if I have been given option, I start with cyclosporin first, because tofacitinib.
Cyclosporin has already been tried, madam.
Already tried.
If cyclosporin has not worked, I doubt tofacitinib will work.
So
I'll go for eczema laser for this.
okay, for the whole scalp.
For the whole scalp, yeah,
Right.
that was
Can I comment?
Yes, sir. So please.
Yes.
See, there is a song, ek se bala do se bala teen.
Right, sir.
So here you have to go for combinations. So you can take tofacitinib, you can also give methotrexate to these people. In addition, because the hair is not there, you can go for phototherapy. You can combine all this and then you may get results.
So don't you think that if you combine more immunosuppressant, the patient will be in a more immunosuppressant if you combine two or more, like cyclosporin, tofacitinib?
You are afraid when you are using one also. The best thing for a patient with alopecia areata, tell them that it is a harmless disease, don't take treatment.
Right.
So once they go in for treatment, That means you are taking the risk of immunosuppression. But if one is not working, you can combine both. And then you can try to withdraw.
Sir, thank you, sir. Point well taken. We have started this girl on a tofacitinib 5 milligram. This is a photograph of 4 weeks, after 3 months, 6 months, and for 8 months. So she responded very well to the tofacitinib, and she is still on a tofacitinib 5 milligram 1 mg. Now my other patients.
How will you stop?
Sir, we will come to that, sir. We will come to that. So in alopecia areata, it is a CD8 lymphocytes which causes the upregulation of IL-15 and responsible for the inflammatory response around the hair follicle. And tofacitinib inhibits that response. Now your question, sir. Will it be stopped abruptly or one should taper the tofacitinib?
Then normally the recommendation says if it doesn't work after 4 months, like 16 weeks, then you have to inhibit.
It has worked wonderfully in this girl. What will you take after 1 year? She is having for the last 14 years 5 milligram 1 mg. What will be your response in that?
I think we have to taper because there is no such recommendation anywhere. But in practice, I do taper. Like suppose I am giving twice daily,
right.
Then I increase to once daily. Then after that I stop.
So you want to say that it is better to taper than stop abruptly. How many people agree with this?
One thing.
Hello. Sir, please.
One thing, in South India there was a webinar. They had been treating tofacitinib orally. After 2 years they found failure, in which they had added tricot pulse therapy, and it responded. After 1 year, yes. And they had shown results, and they had to repeat this each time there was a failure. So they have combined tricot injections along with your.
Sir, I am talking about this female, 19 years old female. Would you advise the tricot injections in female?
No, I'm telling in the webinar. The other is you can use baricitinib, which has been approved by FDA. It works better than tofacitinib, so maybe that can be tried topically.
Topically, baricitinib, is it available over here?
It's not available, but it's been approved by FDA. So that's what I'm saying.
Tapering, it is better to go for alternate days, 1 day 2, 1 day 1.
Sir.
Instead of giving.
There are very good papers who suggest that dose tapering is better option than withdrawal of the drugs, number one. And in this, they say that the flare-free intervals were about 7 months if there is an immediate withdrawal and around 21 months if there is a dose reductions. So dose reduction strategy seems to preferable in comparison to immediate withdrawal of drug. Now, how will you do the dose reductions in that? Say start 5 milligram per BD to 5 milligram 1 MOD. Then sir said it is 5 milligram alternate day. Then what said?
No. 5 milligram BD 1 day, 5 milligram OD 1 day.
Right, sir.
That you give for some time. Then you go for 5 milligram daily. So that way each time you see whether the person is losing hair or not.
So message is 5 milligram 1 BD for
One
till
day.
you get the proper response.
Yeah, then 5 milligram BD 1 day. Next day 1 OD. BD, OD, BD, OD. Alternate days.
This is
we reduce the steroid doses also.
And another thing is that if you really want to do that 5 milligram 1 BD to 5 milligram OD for a month, what I am doing in this patient, then 5 milligram alternate day for another month, and then combined with a minoxidil topical in this patient to continue to see the response.
Before that, 5 milligram twice weekly also you can continue.
You can continue for that. So, sorry?
Twice weekly maintenance. 1 day Friday.
The maintenance after that twice weekly, sir.
Can be done, sir. Can be done. Can be done. So this is about this case.
So I just want to add one thing. So basically, we have another novel strategy to get rid of this. So although it may seem paradoxical, when you start tofacitinib, you sensitize the patient with 2% DPCP. Patient gets sensitized, although he is on a broad spectrum cytokine inhibitor. So that's the paradox. And the advantage of starting both together is you see a more rapid response, so the patient has more faith in the therapy. You can also taper it, after 3 months instead of waiting for 6 months to taper. And as Sir said, you can taper it down, and so much so that you can stop tofacitinib after around 9 months to 1 year, and you can maintain only with sensitization with DPCTB. So this strategy is not only economical, it sees earlier results also, and you avoid, monitoring for tofacitinib, because tofacitinib monitoring is also very expensive.
But see, the DPC sensitizations is sometimes more immediate allergic reactions with that.
No, even the treating doctor also, that's not the point. We take precautions. Over a period of time, you see wonderful results. I've been doing this for the past 4 years. I've been sensitized myself. That's not the point. The point is we have to think for the patient in cases of extensive alopecia areata. You cannot give DPC, you cannot give tofacitinib to a growing child, for 10 years. It's not possible.
Point well taken, sir. Now, for the paucity of time,
two things. Regarding your comment, do you have any, I have done that, by the way, but do you have any literature support?
Yes, but there is a paper which is going to get published.
Yeah, the thing is, you see, I have done it, but the problem with it is, as you just mentioned to begin with, the problem is that tofacitinib would inhibit the functioning of DPC.
Yes, exactly.
So that's the problem.
Right.
So as I said, I've been there, done that, but theoretically, it's there is a problem there. The other thing which I want to talk to you about is tapering with tofacitinib. So what I do is I do trichoscopy control. So that's probably a little better than clinical control. That means you keep doing a trichoscopy, looking at evidence of recurrence of activity to decide on reduction or increase. And that's probably a little better, and you can probably act a little earlier than you would if you're doing a clinical monitoring or clinical control.
Point well taken, sir, because of shortage of time.
Can you end up the session? So yeah.
Just one case alone. Now this is a case of vitiligo, 21 years old female, vitiligo patches periorbital, and since comorbidity with hypothyroidism. This was the patient. All sets of vitiligo treatment, including a conventional immunosuppressant, were proved purposeless in this patient and or provided some temporary relief. Lab investigation is ESR is around 14, the Montus text is around 14 millimeter positive. Chest X-ray was normal. So what will be your take in this patient?
Montauk's more than this doesn't say that it is active tuberculosis. It can be due to sensitization also. So in that
Montauk's can be positive because of BCG vaccinations or because of the atypical mycobacteria. It can be positive. So it cannot be a reliable indicator, right?
What should be the screen test? Montauk's or this TV Gold or Inter?
Coming to that, sir. No, there is a study which says that the TST, that is tuberculosis skin test, is 0 in this patient. If you see that like here. And if due to IGRA, that is interferon gamma release assay, it is positive around 30.6% when the patient is on tofacitinib. So first of all, IGRA is important in comparison to this. But in a country like India, we have it is around 2100 or 2500 cost of IGRA. Most of the people do not afford this. So we can rely on this chest X-ray and the Montauk's test. Even I have consulted with a rheumatologist and many physicians, they say 14-15 millimeter of this Montauk's positive reaction is insignificant.
For that purpose, even if it is the IGRA is positive, they give a profile like
But my question is, most of these patients, they are on the immunosuppressants.
So you must mention 15 milligram at what TU? 1 TU or 5 TU or 10 TU?
1 TU, sir.
1 TU is hardly ever used.
What they have used? 10 TUs?
No. It's either 5 or 10.
So I don't know what are these TUs, but the reactions which have been given on that patients.
So I'll just, I think I need to...
You just given an idea regarding that.
Yeah, so It's really important.
So when you talk in terms of the tuberculin skin test, remember, let us say if you're using 10 TU, anything beyond 5 millimeter becomes important. But if you're using 5 TU, I would agree with you that yes, 10 millimeters is probably the cutoff. But if you're using 1 TU, which is not used in India, there, your 15 milligram, I would completely agree. But remember, in India, nobody uses 1 TU. Your rheumatologist probably doesn't know that. He's probably read the Western literature where they always use 1 TU. And that is the problem. In India,
he wrote me in my prescriptions that for this 14 milligram,
this is the problem in extrapolating.
You can go ahead with the medication.
That's the problem in Western literature. You see, people, we read the Western books and we extrapolate that to our patients. In our country, we don't use. So in our country, mostly people are using 5 and 10. So if you're using 5 TU, which is most common, so 10 millimeters. If you're using 10 TU, it's 5 millimeters. So that becomes really important, and if you do develop either of these, as you rightly mentioned, IGRA is much more reliable. But the problem is, people are not doing IGRA. If you are only doing a TST, it's always better. If your tuberculin is positive, again, I'll repeat, depending on the number of TUs used, it's always better to start HR. So start HR, do HR for a period of 2 months, 1 month you wait, after the end of 1 month, you start the drug, continue HR, and you can use for, again, there is a little bit of variation, some people talk about 2 months, some people talk about 3 months, so that's infection, but remember, before you do HR, you need to rule out that disease. So you have a positive, let us say IGRA or a positive bond to, rule out disease first, because if you've got disease, then you have to use the entire drug, you have to use the entire thing, and I've seen people doing this, they see a TU positive or an IGRA positive and start HR. But remember, that person might have actually disease and not infection. So then you have to use the entire ATT. So that's probably
right, sir. Point well taken, sir. So this is the response of this patient.
According to recent guideline, HR should be for 4 months. And after starting 1 month, you can start the drug. So we can now wind up
Just one case. Just one case. Now this is a case of Parthenium dermatitis. 64 years male, refractory case of Parthenium-induced dermatitis. Known case of hypertension, all on pelvis RH, erythematous periodic diffuse. Initially, in summer sedation, later become all year round. First test was positive with the Parthenium. Multiple treatment was given. Initially responded to treatment, but later become resistant. This was a photograph of this patient. PVC, LT, and serum were normal. So, what will be your treatment of choice? These are the drugs for the which can be used. So how will you proceed in this case?
Tofacitinib.
Azathioprine.
Tofacitinib.
Right, sir. Azathioprine. Now this is the response of azathioprine in one of my patients. Anagen effluvium within 6 days. Within 6 days. And I have seen in 4 or 5 patients, including a girl of 60 years old, with this anagen effluvium. So one should be very, very diligent and careful before using azathioprine. And these are the result of the stopping the drug azathioprine. This patient is continuing on tofacitinib.
Initially systemic corticosteroids, then after that steroids were included.
Sir, the problem is, I was talking about 60-year-old remain hypertensive patients.
We don't need steroids.
Sir, we have given azathioprine thousands of patients. And
might possible.
Sir, I have one patient. Sir, one patient of mine, tofacitinib, has developed buccal carcinoma. That should not stop me from prescribing tofacitinib. That is the reason.
But if one patient comes to you like this now,
yeah. So in that condition, I have already.
So my intention is just one should be vigilant or diligent before using this azathioprine, because lot of medical legal complications are there nowadays. So all the tests and everything should be there. This was
Dr. Srivastav, I think we should wind up now. We are getting late.
So let's wind up. Thank you.
Okay.
Thank you, sir. Thank you, my panelists and all audience as a panelist for
Thank
their
you,
wonderful.
and thank you, panelist Dr. Puhan, and thank you all the delegates who have given their valuable suggestions.
This is the case of bullous pemphigoid in which I have used this, and these are the results of that. Thank you.
Thank you, chairpersons, panelists, speaker, and moderator for the sessions. Now request all the faculties of the session collect the memento. I request Professor Dr. Gurmohan Singh sir to kindly come and felicitate our faculty. Request Dr. Aesthetica to kindly escort Gurmohan Singh sir.
There are a few announcements. One, there's a gift waiting for you. You go to the JRK counter. There you'll get the gift. Number two, because there's less light over here, you want to talk, you can put your hands up so that the mic can go to you. And then you can talk. That will be better. Sir.
We'll start the next session.
And third is, those who are speaking over here, kindly stick to the time, otherwise it will be रात का 12 बज जाएगा, हमारे भी 12 बज जाएगा. So if you stick to the time, then I think we can finish on time. Thank you very much.
Yes, sir. Now we'll move on to the next session, which is sponsored by La Pristine, that is on sunscreen. I request Chairperson Dr. Manjulata Das ma'am, Dr. Dinesh Mathur sir to kindly come onto the stage and chair the session.
Dr. Irene?
बढ़ने के बाद लगाना प्रॉब्लम है.
So thank you very much, and now we have got a sponsored session of Lab Stream on that is on the sunscreen, how to choose an ideal one, and the speaker is Dr. Irene Matthews. Can we put up the Irene Matthews TV?
बढ़ने के बाद लगाना प्रॉब्लम हो जाता है. ये कहाँ पर वही करनी
Dr. Irene Matthews, please, and our panelist of this session, panelists of this session.
Can you put the CV of Dr. Irene Matthews, please? Ames Patna. All right. So Dr. Irene Matthews is a assistant professor in the Department of Dermatology, Ames Patna. Welcome, and your laptop is working or not? See that whether all the panelists are available or not. Dr. Ravi Vikram Singh, Dr. Abhishek Jha, Dr. Rajneesh Kumar, Dr. Arpita, Dr. Deepthi Bishoy, and Dr. Swati. Oh yes, yes, we know. I was just ensuring whether these people are available or not.
Attendance ले रहा है.
Huh?
Attendance ले रहा है.
No, because in the last panel session, there was only Manas was sitting. We could have taken another Manas at the time also.
Good morning, everyone.
I'd like to thank the organizers, Aesthetica Asia, for kindly inviting me. And a very good morning to the audience, the organizers, and respected chairpersons. My topic is something very basic but yet hotly contested. So it's on how to choose the ideal sunscreen. And I have no conflicting interests. So before chasing the unicorn that is the ideal sunscreen, I'd like to say that photo protection sunscreens are perhaps should be perhaps the last option. So even though sunscreens, even if we choose the very ideal one, which is a myth, sun avoidance in peak hours and wearing protective clothing is the primary basis of photo protection. So keeping that in mind, we'll see how we can choose an ideal sunscreen. I'm primarily dealing with the theoretical aspects and to provide a background for our panel discussion, which I'll hope will provide a deep clinical insight. So this is the UV spectrum that we all know, just a reminder for the residents. So we have the visible light, the UVA1, UVA2 and the UVB. All of these have significant effects, and we all remember the mnemonic that UVB, which is the shorter wavelength, affects primarily the epidermis and it causes burns, it causes pigmentation. UVA has deeper penetration and it causes aging and wrinkles in addition to some pigmentation. And now we have the upcoming wavelength which has a lot of impact on skin, which is a high energy blue light. So this is the wavelength of the UV light, and just to remember as we go forward that UVB and UVA2 are close in wavelength and have similar effects, and UVA1 is the true longer wavelength one which affects the dermis. So mostly when I talk about UVB, I am talking about UVB and UVA2, and UVA usually refers to UVA1. So this is the effects that we are trying to prevent as dermatologists, that is UVB and UVA2, which causes the epidermal effects and later malignancy, UVA1 which causes aging. But more importantly, it has a significant implication in production of pigmentation, especially in the darker phototypes, which is relevant to us as Indians. So, and the high energy blue light, which is has a significant source from the screen use, is also important in pigmentation in darker phototypes or persistent pigment darkening. So this is just a reminder that we previously used to have physical sunscreens, now known as inorganic sunscreens, and then the chemical sunscreens or the organic sunscreens or aromatics. So the organics one primarily work by absorbing the UV wavelengths and converting it into a very small negligible amount of heat, while the others work by reflection, scattering or absorption. And just a reminder that the organic compounds or the previous chemical sunscreens are aromatics, and this chemical structure has an implication while we are choosing the sunscreen. So this is what we typically know about sunscreen, that there are systemics and topicals, organics and inorganics. And mostly we know the spectrum that the inorganic ones are broad spectrum anyway, and the organic ones are either UVA, UVB predominant, or they can be a combined one. But what we need to remember is that the visible light protection that we are looking for comes only from tinted sunscreen, which contains a significant amount of iron oxide. So the white physical sunscreens definitely do not, or the chemical sunscreens do not provide a visible light protection, which is definitely important for Indians for pigmentation. So this is the myth that is the ideal sunscreen, where the physician has a long list of demands, which is photostable, water resistant, the adequate protection against the all wavelength, non-comedogenicy, no allergic reactions or irritant reactions, no systemic toxicity, no vitamin D deficiency, which is a tall order. But at the same time, the patient has a long list of other demands, which is perhaps more important, because the best sunscreen is the one that the patient is willing to apply. So they need a low-cost one, which is light and easily spreadable, looks good, has no odor, has no white cast, and has no darkening, which is often complained by Indian patients, and no itching, burning, or redness. Especially on the eyelids, this is a frequent complaint from patients. So while choosing an ideal sunscreen, I'll have a short list of how to we read the bottle. So we have the most important factors here, that is the SPF and the PA protection or the UVA protection. So we all know what an SPF means. SPF is actually measuring the amount of protection provided against burning or MED. So the American Academy of Dermatology for routine use recommends at least 30 SPF, and commonly in addition to 15 we have 30, 50 and 80 or even higher in the market. So AAD kind of recommends it for all phototypes and does not discriminate, but their primary concern of course is malignancy prevention. which may not be a great concern, but for our skin types, definitely pigmentation is a major concern. So, but when we are trying to achieve this SPF, we have plenty of real life issues. This is based on a good quantity application and proper reapplication within 2 to 4 hours, and also in conditions where there's not much water or sweat. So we have to remember that the SPF on the label may not often transfer to what is happening in the real life. So we recommend 2 milligram per centimeter square. Despite counseling, most patients will apply 1 milligram or less, which actually reduces their SPF to 1/3. Combined with reapplication, so the effective SPF is very low. So if you want to achieve 30, you may have to go with 50 or higher. So this is how the UVA1 protection is measured, which refers to the pluses on the box, where usually we prefer at least PA3 plus, which produces at least 90% of UVA filter, preventing aging and pigmentation, and as a filter time of 8 to 12 hours, which does not translate to real life scenarios. And this is based on the amount of pigmentation rather than burning as in SPF. So visible light, we have already covered that. Tinted sunscreens, we require 3% at least of iron oxide. So it is important to read the label and make sure that the tinted sunscreen has a quite high concentration of iron oxide if we are looking to protect against visible light. So other than the SPF and PA and visible light protection, we want to make sure that the sunscreen is staying on the skin, especially if these are active individuals. So previously we used to have random labels like waterproof, sweatproof. So the currently regulated labeling that is accepted based on guidelines are either they can be labeled water resistant and they can be labeled very water resistant. Water resistant, these mean that they can retain the SPF after 40 or 80 minutes of sweating or water activity. So this just means immersion for 20 minutes followed by drying for 5 minutes followed by again immersion for 20 minutes. In real life scenarios, patient is going to sweat, they are going to wipe their face. So it would be definitely better to reapply. So this image kind of shows what the doctor is expecting from the patient when they ask to apply sunscreens. And we prescribe our conventional products like emulsions, emulgels and gels, which are, many of them are quite cosmetic on the face. Then if you are looking for cheaper options, especially for the body, ointments, paste and lotions can be preferred. And why we use emulsions is that most of the sunscreens, especially the cosmetic ones, are emulsions. This is because the organic and inorganic active ingredients are actually all oil soluble and not water soluble. So most of our sunscreens are oil and water emulsions, and they are to maintain their cosmesis. It can be an ointment, but then the cosmesis is generally very poor. But what the patient is kind of expecting, especially if they are approaching us for aesthetic concerns, is something like this. They want to either use a sunscreen stick, which is very popular, though expensive. They want to use a powder, which sort of looks like compacts, or they want to use sprays, or they are kind of happy with the sunscreen incorporated into makeup. So there are plenty of studies which shows that most of these do not provide the SPF protection that is there in the label. The spray is almost always a pure chemical sunscreen or an inorganic sunscreen, because aerosolized inorganic compounds like zinc oxide has definite problems when they are inhaled. And these pure chemical sunscreens are going to be very patchy and they need extensive repeated layers of application. So it can be suggested, if the patient is definitely into reapplication conveniently, it can be also reapplication rather than as a primary sunscreen. Same with the sunscreen sticks. It needs plenty of swipes. A single swipe does not provide the labeled SPF. Most of them require 3 to 4 to 5 swipes. By that time, the cosmetic elegance provided by the sunscreen stick may not be an important indicator. So basically, the sunscreen incorporated into makeup can provide an extra layer of protection in a patient who is already using a good SPF sunscreen, and the others can help in reapplication, probably. So this is just a general guide to picking the sunscreen formulation. So we have to take the patient's lifestyle into consideration, but make sure we educate them on achieving adequate protection. What are the situations where we use pure physical or inorganic sunscreen? We'll go into more detail that, especially in the panel discussion. Allergic contact dermatitis, irritant contact dermatitis, concern about systemic safety of the topicals which are applied, concern about coral safety in individuals who are environmentally concerned. And but the problem is that previously physical sunscreens used to have a poor cosmesis. Now most of them are nanoparticles or they are tinted. So the white cast issue is usually not a problem. Earlier there was a concern that these nanoparticles may actually penetrate into the dermis and thereafter into the bloodstream, but most recent studies show that these don't go into the bloodstream. So nanoparticle pure inorganic sunscreens are generally safe. So coming to contact dermatitis, PAVA was the most important implicated agent. Now it is absent from most sunscreens, especially the expensive ones. And fragrances are top of all rather than the active more common cause of contact dermatitis, so it is important to read the label carefully, especially in atopics and those prone to contact dermatitis. Oxybenzone is the most common among the active ingredients, and even though that is less than 1% in the people who are allergic to sunscreens. Ideal way would be, of course, to avoid oxybenzone, do a patch test for cosmetic and fragrance series and choose an alternative. Often not possible. We can always try pure physical sunscreens and read the label for the common allergens. So there are few emerging concerns, that is oxybenzone and octinoxate, which is applied by swimmers, that it causes bleaching of corals and anemones and involving the marine ecosystem. So that might be a reason why we push for physical sunscreens. There is significant evidence which has accumulated from 2008 to 2022, so it definitely needs to be considered as more and more people apply sunscreens. And there is also some evidence that these chemical sunscreens or the aromatics could be endocrine disruptors. So that is the reason why we would definitely use physical sunscreens in children and probably in pregnant women. And about its use in adolescents and adults, we will definitely wait for more data. But considering the amount of information that is already there are animal studies which prove that these are endocrine disruptors and that there are significant blood levels in human beings when they apply sunscreen to large areas in a very compliant and adequate way. So definitely these things should be kept in mind while we are choosing a sunscreen. So there are pros and cons of applying sunscreens in healthy children. We'll deal with this more in panel discussion. So I'll just to wind up by saying ideal sunscreen is a myth, a unicorn that we are chasing. But the other alternative is this, that is basically covering the entire body with something that is very, very photoprotective. So it is not possible and the patient will not be compliant. And we have to strike a balance between getting a sunscreen that the patient will apply and achieving adequate levels of protection that we require. Thank you.
Thanks, Dr. Matthew, for your nice presentation. What is an ideal sunscreen? What are SPF, appropriate SPF? What are the side effects and what are the formulations? The questions regarding an ideal sunscreen may be put in the panel discussion, and now there will be a panel discussion on the topic. And I request our panelists to chair Dr. Ravi Vikram Singh. He is not there. Dr. Abhishek Jha. He is also not there. Dr. Rajnish Kumar. He is not there. And Dr. Arpita Nivedita Rao. Anybody interested to be? Yeah.
Can I ask Dr. Srinivas to be here, please? Because your inputs will be very... And Dr. Manas. Come on.
You can be in the crowd.
Sunscreen not the area.
All right.
Dr. Dipti Bisoyi.
Oh, yeah. You are searching in YouTube. In YouTube, you will get beauty and exercise.
This is yesterday's, right?
Yes.
This one?
It's going on. If you go to Facebook page, Aesthetica here, then you will find it.
So I welcome all our panelists. All our panelists, Dr. Srinivas and Dr. Manas, they are very sportive and outstanding in their talk. So I welcome all the panelists, Dr. Dipti and Dr. Arpita. Yeah.
I thank all my eminent panelists for being so supportive. So the discussion here is the same, how to choose an ideal sunscreen. So the first question is kind of all-encompassing. What are the common reasons for poor compliance to sunscreen, basically what the patients are complaining, and how do you tackle these in OPD? Sir, would you like to start with this?
Poor compliance is basically the cost. It is very expensive. Like you have to tell the patient that in 1 month you will have to use 3 bottles. If 1 bottle comes for 3 months, you are not using it properly. So it comes to nearly 700 to 800 rupees. So that is 2,500 rupees for a sunscreen. Is not really very cheap. And how to tackle this? Like first of all, you will have to try to avoid prescribing sunscreens. That is one of the important ways. Prescribe it only when it is very much needed. And in those cases where it is very much needed, you have to give them the proper instructions as to how it has to be applied. And it is about 2.5 ml each time. That comes to half a teaspoon for the face, and it has to be applied every 3 to 4 times. So for persons who are indoors, they can apply less frequently. But people outside, in addition, they have to apply it when they are going out. For all this, you will have to tell them, which very few people can do it. And many cases where we prescribe sunscreen, it is not needed.
So, as Dr. Srinivas has mentioned, we see so many prescriptions where a sunscreen is absolutely not needed. Children being told that you must use a sunscreen prophylactically. Remember, you must tell these people a lot of these advice in Western literature are based on a higher incidence of malignancies. That's not a problem which we have. And this, use of sunscreens as a prophylactic in general, and this is by dermatologists, that, everybody must use a sunscreen. It's kind of a, I think that is, and then they use a sunscreen as a moisturizer, I always tell people, please, if you have to use a sunscreen like a moisturizer, don't use it.
How about when people ask that they are, most of them, they are indoor and they don't want to?
So indoor, if there is a condition which needs a sunscreen, and if the patient is indoors, definitely some amount of protection will be required. In indoors, substantivity becomes higher. Okay, and that basically means that the sunscreen remains on the skin for longer periods. And because you don't sweat and your substantivity significantly goes up, so you can use it probably even twice. So even twice in a day is good enough. But you are moving outside, and most seasons in our country, it has to be used every 4 hours. In fact, people talk about actually every 3 to 4 hours. Yeah, so now if you're talking in terms of usage every 3 hours, it is really like an impossible situation. So use it in someone who you are convinced and the patient is convinced actually needs a sunscreen. So
Patient mostly ask that I'm living in the inside AC. Why should I use that?
See, I tell them that here I got a glass on my table. I write important notes and keep beneath the glass, And over a period of time that fades. So when you go outside, you find the signboards are fading. That is because of the ultraviolet rays. You write something and keep it on your table, that also fades. That means the ultraviolet light is there. And you should also tell them that if you are able to see a person during daytime, you are able to see because light is there. And that light also includes ultraviolet light.
Yes.
And the only place where we have to use sunscreen is something like discoid lupus erythematosus. Not even polymorphic light eruption. Polymorphic light eruptions, most cases don't need sunscreens.
Sir, most of the people, they are working with computer. And most of the people, they are working with computer and also
That has come in recently now, and they are telling about the blue light, and that has got the ferrous. Now there is no way, I don't know how they found out that ferrous sulfate, because we cannot do MED, we cannot do MPD, so how to standardize that, I don't know.
Dr. Deepti, would you like to address any of the concerns?
Regarding non-compliance, I thought when patients are coming to us, they are asking that when to apply sunscreen, because they are applying so many things like your makeup, concealer, everything. If we will make them understand that yes, sunscreen is according to the patient's choice. Sunscreen is having everything. It is having moisturizer, some kind of tinted things, and according to the patients, if you ask them that yes, if what you need and what is your thing, everything is there, and you can apply it 2 to 3 times, then I think compliance will be much better.
So I think everything has been covered. Another point is allergy contact dermatitis. They develop allergy contact dermatitis. They also avoid. So we have to choose one formulation which is applicable for them. Then they will be.
So I think the consensus of yes.
I will give you one little example. So I'll give you one little example. You see, I do a lot of long distance cycling. And you know what happens is, it's recommended. It's recommended to use this.
If you have the sound on.
Hello. Okay. So when you're doing, long distance cycling, like the entire day, so it's recommended, again in inverted commas, to use a sunscreen. But you know what happens? You land up with severe irritation in the eyes. You cannot ride. So it's, I have stopped using a sunscreen. So again, when we talk about long distance, very intermittent sun exposure, long duration, very intermittent, not very regular sun exposure, which is not leading to the PPD. So, that is, so if you are using intermittently, again, I don't think a sunscreen is required.
Can I just add one thing? So,
Basically, sunscreen takes away what it is supposed to give. It decreases your ability to tolerate sunlight. You use sunlight, your natural hardening decreases. So you have to go on using more sunlight. So it creates a demand for itself.
I request the panelists to only involve in the discussion. If you involve audience, it's killing time.
So I think for this question, the consensus of the panelists is that apply sunscreen or prescribe it only when it is absolutely required. Then be prepared to really commit to counseling the patient, choosing a proper formulation and integrate it to their lifestyle, and make sure that the patient is also willing for that commitment. Otherwise, they are probably wasting their money. I'd just like to add that perhaps in long distance cycling, a hat would be the practical option.
Another thing you must tell patients is that sunscreens require a depth for the filters to work. Now, if you are not giving it that depth, you might as well not use it, because the sunscreen is not going to work. So a very thin film, yes, a physical blocker would work, and primarily a physical blocker containing iron oxide, which patients really don't want to use. So otherwise a chemical product would require depth, because it will not, this conversion of heat to light energy will not occur at the first set of molecules. Light to heat energy will, sorry for the ulta, so will not occur at the first, level of molecules. So that depth is going to be required, and it's very difficult in our country to actually use, 3 grams.
So the second question is choice of SPF and the spectrum of UV protection and the scenarios, and when do you opt for visible light protection?
I think visible light protection is something which is good for any sunscreen. The commonest indication where we use a sunscreen is melasma. That is the commonest indication where we use melasma, and we know visible light impacts melasma. So therefore a pure chemical sunscreen is not a very great agent. Yes, it would work to an extent, but it would not work completely in case you want to give really good protection. In our country, a lot of poor responses in melasma are actually to do with sunscreen use and not to do with the drugs that are being used. So I mean, I have seen this in umpteen number of cases. Once a patient uses a sunscreen properly, the patient responds to the same other regimen that you are using, well, whereas it doesn't work in other situations.
I think Dr. Arpita has something to add.
I think this has been covered in your talk itself. So SPF at least 30 we should choose in our type, and UV protection we should visible light protection. Sir has summed up, so nothing more to add.
In SPF, it is 25% enough, but more SPF is required when seeing the clinical situations. And but the problem is that if the SPF level, SPF 30, 40, 50 increasing, then the greasiness and the stickiness is more. And in UV protection, so it's A and B, broad spectrum is preferable. And in children, mostly the physical sunscreen is better.
Can anyone of the panelists respond? How much UV protection is cap or Indian turban and all these things they give?
So clothing and UV protection, now that is another chapter. Now there are actually in the US you have clothes with the SPF mentioned. But one more thing which I'd like, UVAPF. Yeah. So now one thing one thing which is really important is to know what SPF stands for. See, SPF is a measure of ultraviolet D protection, and that is really important. We call it sunburn, B for sunburn. You mentioned that in your. So remember, SPF and pigment protection in our kind of skin do not correlate that well. So that is really important. So SPF in itself as a measure of protection, let us say in a condition such as melasma, yes, you will have to look at the PA rating, etc., which are probably much more important.
Can I ask one question? In melasma, should we apply over the entire face or can we apply it only over the affected area?
Definitely entire face.
Why there is no melasma there? And some of these areas are not going to get, and it is a costly drug. So nowadays what I have started doing is, I apply 3 layers over the affected area. Apply once, apply second time, apply third time in that area. Now I have not done the studies for this, but this is a sort of tip which I am telling. That way you reduce the amount of sunscreen that is used. And another thing also, even the foundation also has a good SPF. So, or if you use the cosmetic camouflage, that has got an SPF of 50, the one that is available cosmetic, and that stays for a long time. Why should we use sunscreen so frequently? Why should we use it at 2.5 hours? Because sunscreen is like petrol. As the vehicle goes, it gets consumed. It gets exhausted. When it is going uphill, the more petrol is consumed. So when there is more sunlight, more sunscreen is used up. That is why when you go out, you have to use more amount of sunscreen.
Sir, one question. Does it vary with this, what you told now, 30% SPF, you are applying 3 times, 3 coat. And if you use 50% SPF in that area, what is the difference?
The basic thing is, we apply very less quantity. So I said, sunscreen SPF 30 applied over SPF 30 is still 30 only. It does not make 45 or 60. It does not increase. But you ensure that the person applies it properly. Otherwise, they will apply a very thin layer. It won't be there. So what it is, you have to tell them that sunscreen is a thick layer. You look, there is a window here. If the screen is very thin, the light will come through. If you want the light to stop, you require a thick layer. So you will have to apply it 2-3 times to get a thick layer over there. That is the reason why it is red. Otherwise, it is not that the SPF goes on increasing by applying the same sunscreen. And there is no need to wash the sunscreen before applying. You can apply sunscreen above sunscreen except in only one condition where you have to wash the sunscreen. That is in case of Parthenium dermatitis. In Parthenium dermatitis, if you are giving sunscreen, it acts like a trap. It traps the antigen. And then above that you apply the sunscreen, you are occluding the antigen. So that can cause worsening.
melasma, what I normally do is I tell them, as Dr. Srinivas has mentioned, in addition, wherever involvement is there, but in certain situations, for example, oral contraceptive, I tell them to apply in the upper lip as well, because the upper lip is an area which is involved in OC-induced melasma. So areas involved and probably areas which are likely to be involved.
You talked about the trapping of the antigen in Parthian. Then what exactly this message to be given to them?
Wash karke lagao. Wash karke lagao.
I think
It is a barrier. Sunscreen acts also as a barrier, as a protective barrier.
In the shortage of time, we can go to the next question. I think the panelists here agree that the scenario determines how we choose the sunscreen. And since pigmentation is a very, very important part of use in darker skin types, we should definitely have adequate UVA and visible light protection, otherwise it may defeat the purpose. So what are your preferred sunscreen formulations and reasons for the choice?
Okay, now in regarding to formulation, this is not to do with only sunscreens. It's generally to do with formulations of all topicals, let us say in our country. Now, what we need to understand is that, there have been studies done which have actually shown that the formulation decides compliance. So if you are using a formulation, I think you also mentioned that, if you are using a formulation which the patient is not likely to use, that particular formulation will not work because the patient will not apply. So probably the acceptability of the sunscreen is much, much more important than what you think is medically a better thing to do.
But the drawback is each of that costs so much. So which one suits them, finding is very difficult. So ideally, I think we should have 5 to 6 different sunscreen in our clinic. Ask the patient to try that, buy what he likes.
I think trying out the sunscreen samples definitely help in enforcing compliance. So, contact dermatitis, I think we are running short of time. We have
yes, we have almost crossed the
30 minutes. So we have, I think, covered the contact dermatitis, so I'll skip that question. And I think this is something all the panelists have strong opinions on, and we have decided that we will not routinely use it in Indian children.
It is impossible for the child to use sunscreen, school-going child. Kaise lagayega? It is not possible.
Parents are desperate to use a sunscreen for their children. वो स्कूल में ना 15 मिनट खेलने जाता है, उसके लिए sunscreen चाहिए.
In PMLA, it prevents the hardening and it doesn't really stop the problem at all.
You can wind up the session, Doctor.
I thank all the eminent panelists.
Before she throws us out, let us go.
I thank all the panelists for being so sporting and having a great discussion. Thank you.
All the faculties of the session to kindly I request R.N. Datta sir to kindly participate the faculty. We'll move on to the next session, which is on procedural dermatology. It is sponsored by Hetero Healthcare. So, for the session, I request the chairperson, Dr. Midula Patropal ma'am, Dr. S.K. Bose sir, to kindly come onto the stage and chair the session.
So, I'll invite Dr. Aditi Snehal for this session of use of TCA in dermatology. Dr. Aditi Snehal. Now we can start the session.
नीचे हो गया लेकिन स्टेबल हो गया। हाँ लेकिन ये सही नहीं है, इसको बदल लेंगे।
Good morning, everybody. I am Dr. Aditi Snehal, SR from AIIMS Patna. I will be talking on TCA in dermatology. So, as we know, TCA is a chemical agent with various concentrations used in different cosmetic and therapeutic procedures. TCA is used most commonly for cauterizing and homeostatic agent. It is analog of acetic acid and it is a strong acid with pH of 0.26. It is stored in amber colored bottles as it acquires moisture from the atmosphere, and so it is and gets degenerated from the sunlight. It is prepared as 100% TCA can be prepared by addition of 227 ml of water to 500 gram of TCA, which comes in crystals. The mechanism action, as we all know, is coagulative necrosis of the cells with extensive protein denaturation and structural cell death. Histologically, precipitation and coagulation of the skin proteins through hydrolysis and leading to inflammation, coagulative necrosis of the cell of epidermis, connective tissue of papillary dermis and upper reticular dermis. It is followed by epidermal and dermal regeneration with collagen deposition and normalization of elastin tissue. The destructive activity is due to the acidic nature. The use in dermatology are chemical peels like photoaging, acne scar, pigmentation, solar lentigen, for TCA cross, especially for the ice pick scars of acne, chemical partial matrixectomy for ingrown toenail, for wart, molluscum, dermatosis, DPN, seborrheic keratosis, skin tag, xanthelasma, and corn foot. So chemical peel, basically TCA can be used in different concentrations, where very superficial peel can be done with 10 to 25% of concentration, which is used in skin rejuvenation, dyschromias, mild photo damage. 35 to 50% can be used in mild, medium depth peel for moderate photo damage, acne scars, and more than 50% is usually not recommended as it can cause scarring. So indication of chemical peels with TCA can be with photo damaged skin, in acne vulgaris, in pigmentation, wrinkles and scars. And contraindications are tetracycline and oral isotretinoin, especially if there is a use in 6 months. Keloidal tendency for medium and deep peels, irritated skin and active infection, mostly and dermatitis like herpes. So a priming is done for the peel, where 2 to 4 weeks patient is said to apply, most commonly topical retinoids. It is done for uniform penetration of the peeling agent to shorten wound healing time and to reduce the risk of post-inflammatory hyperpigmentation. So the topical retinoid, it causes thin stratum corneum and enhances the penetration and depth of the peeling agent, enhances the epidermal turnover and reduces the risk of delayed epithelialization, and it can be stopped 1 to 2 days before the chemical peel. Other priming agents which can be used are hydroquinones, kojic acid, azelaic acid, arbutin and liquorides. So the procedure is, first, for every procedure, as we know, consent and photograph should be taken. It is most commonly done in an outpatient procedure. There is no anesthesia used, but for deep peels, medium peels, there can be topical anesthesia used, as there is tingling and pain sensation present after the application. The face is washed with soap and water for degreasing. A supine position with elevation of 45 degrees done, and there can be degreasing also done with alcohol or acetone. The degreasing is to facilitate the uniform penetration of the peeling solution. Vaselines are applied to the sensitive areas like corner of the mouth and nose and eyelids. The peeling solution is poured and applied with a flat brush or cotton tip applicator. Always we have to keep a syringe filled with saline, so that if any dripping is there, any accidental spillage is there, it should be washed off immediately. Peeling solution applied in region in a clockwise or anti-clockwise direction, from forehead to down the chin, across to the other cheeks. And if tears comes from the patient, it should be wiped off immediately, and it can cause pigmented streaks. The solution is spreaded till the hairline, so that there is no demarcation after the peel. During peeling process, skin is cooled off with a continuous fan operating. The peel is kept for 60 seconds to ensure the complete coagulation process. Even redness and frosting is seen, that is the end point. The depth of the peel correlates with the intensity of the frosting. So light frost, superficial peeling, epidermal peel, that is level 1. If there is white frost with erythema showing full so that is level 2. And a solid frost, that is rich white frost, that corresponds to papillary derm peel. So the patient will experience a burning sensation that should be counseled priorly the procedure. And when the desired endpoint is reached, the patient is advised to wash it with water. So the post-peel care, there should be strict photoprotection, bland emollient application, even immediately after the peel. In superficial peel, skin reepithelialization occurs in 3 to 4 days, and medium reepithelialization takes 5 to 7 days. Patient should be reminded not to prick or scratch or rub their face, and emollient should be applied every time if they feel so. Any exudative areas should be treated with antibiotics, and the peel can be repeated for 2 to 4 weeks interval. The complications can be erythema, infection, chemical burns, melia formation, acneiform eruption, allergic contact dermatitis, scarring, and post-inflammatory hypo or hyperpigmentation. Advantages over the other peel is there is no allergic reaction, no systemic toxicity, as the protein are denatured, and that is the end point. It doesn't let it absorb systemically. So there is no need of neutralization. The end point is easy to judge. The depth correlates with the intensity of the frosting, and dilution with water decreases the concentration and terminates the effect if more frosting is seen. So the frosting lasts for 10 to 30 days and erythema lasts for 1 to 2 days. So this is frosting seen where in melasma patient, double coat was applied over the areas where the melasma was more, and this is the end point. So the next is TCA cross, which is the chemical reconstruction of the skin scars, which is mostly done for the ice pick scars. This topical, not TCA cross, but the topical application is also done in freckles. So the priming is done with hydroquinone. It can also be done with tretinoin 2 weeks prior. Focal application of 50 to 100% TCA is applied with a wooden sharp toothpicks. It can be done with 2 weekly intervals. The scar, when the scar is very small and coned, we can use RF probe, which is very pointed and thin, to apply for application of the TCA. Sunscreen is advised to prevent post-inflammatory hyperpigmentation. The advantages are it is safe, minimal invasive, as very topical and spot application is there, efficacious, cost-effective, and the side effects can be secondary scarring, hypo or hyperpigmentation. So as already discussed, it causes coagulative necrosis, causing increase in the collagen production. So the dermal volume increases and the scar is healed. And that there is a remodeling phase where the type 3 collagen is replaced by type 1. And fibroblasts are oriented in the parallel in the epidermis, which leads to a cosmetic better appearance. So we have applied in the freckle, same spot peel, and there was complete, only mild pigmentation was present. So the next use in chemical partial mastectomy, where nail plate excision was done, as it is done in the partial nail aversion. So after cleaning, local infiltration and tourniquet was applied at the MTP joint. Then the nail splitter was done. The nail was removed, and the lateral nail fragment is avulsed. Then it is removed by a twisting to forward direction. Then the tourniquet is released. Petroleum jelly is applied to the surrounding tissue, and the TCA is applied for 30 to 1 minutes without any neutralizing factor. If there is a granulation tissue present, TCA can be used, but it delays the wound healing. But we can use TCA or RFA, or we can surgically cut the granulation tissue, and the hemostasis can be achieved with TCA. Antibiotic ointment is to be given. So this is how TCA application is done for the matrix to be. So matrix is burned so that that area of the nail doesn't come, and so ingrown is then avoided and stopped. Other agents that can be used can be phenol and NaOH, sodium hydroxide. Post-operative care, hemostatic dressing is applied following the procedure for 1 day, and the dressing is removed after a day and cleaned with betadine for twice a day, following soaks of antibiotic and bandages. Leg elevation is advised for 24 hours, and avoid using wearing shoes for 3 days. Analgesics and antibiotics are being given. So next indication is for xanthelasma, where in our setup we use 100% TCA. In an interval of 2 weeks, 1 session or more than 3 sessions can be required. 50% in macular lesions, 70 to 100% for flat, and 100 for thick plaques. The side effects can be hypo or hyperpigmentation, scarring, ectropion. Spillage can cause more damage. So here, like very spot on the area of the TCA, of the xanthelasma, TCA is applied, and the frosting can be seen. TCA can also be used in wart and molluscums. So it is very high success rate is there with warts, and very low morbidity if the sufficient care is applied for the application. So it should be done only by the physician, and it is very helpful as we have very less drugs in pregnancy what comes. So it can be used in pregnancy. Initially the Vaseline is applied to the surrounding skin. Then 80 to 90 or 100% TCA can also be applied. It is the patient is called per week, and the end point is frosting when it dries off. After that, the patient can clean up with water or be swabbed until complete clearance of the lesion occurs. Maximum duration of 6 weeks. Side effects can be pain, burning with scarring. Excessive neutralized with soda if the TCA is applied more. It can be neutralized by soda bicarb. So this is a ward patient where TCA was applied, and the frosting can be seen easily. It can also be done in corn foot, and it usually as keratolytic agent. So low concentrations is applied. Mostly it can also be done for the elevated ulcers margin. So there also we can do a pairing, or TCA 100% can also be applied for better healing. Other indications are DPN, seborrheic keratosis, actinic keratosis, where medium depth peels are applied, freckles, lentitions, skin tan. The contraindications can be obviously hypersensitivity to TCA and malignant conditions where systemic absorption can occur. Advantages of TCA is there is relatively no allergic reactions, no systemic toxicity, no need of neutralization. Dilution with the water decreases the concentration and terminates the effect. In peel, depth correlates with the intensity of frost, and the end point is easy to judge. In case of excess amount of acid application, it should be treated with sodium bicarbonate, liquid soap. The disadvantages are it is more prone to cause post-inflammatory hyperpigmentation in mostly our Indian darker skin types. The concentration of 35% have more chances of scarring, and TCA solutions have low viscosity comparable to to that of water, so it can spread easily and excessive amount can be applied. So there meatus stenosis can also occur. The complication can be erythema infection, chemical burns, premature peeling, melia formation, acne formation, and allergic contact dermatitis, scarring, post-inflammatory, and or hypopigmentation. These are my references. Thank you.
And now I am to introduce the speaker called Dr. Deepti Bisoi. And she will be talking about chemical peels.
दीपक भाई
Very good morning to respected chairpersons and assembled delegates. I am very much thankful to the organizing team and the scientific team to giving me opportunity to talk on the topic chemical peeling, a practical approach. So these are my layouts. So chemical peeling, otherwise called chemoexfoliations, is a method of targeted cutaneous ablation using specific caustic agents that allow for rapid, predictable and uniform thickness of chemoablation to a desired cutaneous depth. Ultimately, it results in improved appearance of skin. So when I searched chemical peeling, I found so many products are available in Amazon, and it is written there that there is an official site, and I clicked on that and I found so many products. I was in the first page and there was 46 pages. So this is, I have put these slides because chemical peeling is so rampant and everyone knows about it, every general people. So they are applying on herself or himself. So to educate in chemical peeling for a dermatologist and also to educate the patient is very important. So these are the indications like your pigmented disorders, inflammatory disorders, scarring and chronoism, and precancerous lesions like acne keratosis. These are the indications. So what are the basis of classifications? We are classifying the chemical peeling superficial, medium and deep. So this is the depth of penetrations determined by the concentrations of the pH, type of peeling agent used, and the anatomical locations where we are applying, and the epidermal integrity and adnexal structure, density and skin thickness. Then the other
important things are cutaneous priming, how we are doing the priming, and applications techniques, then the occlusion and the contact time. So these are the rows showing the superficial yellow arrow, superficial peeling, and the deep peeling in the blue arrow, and the medium depth peels, and the black arrow shows the deep peeling. So superficial peels goes up to 60 micrometer and medium peel goes up to 450 and deep peel up to 600. So this superficial peels act by decreasing the corneal skin adhesion, epidermolysis, and increased dermal collagen deposition. It thins the stratum corneum, increase epidermal thickness, and more even distributions of the melanin. So here the goal here is to achieve the no frosting or level 1 frosting. The level of frosting I will discuss in the later slide. So superficial peels are suitable for all physical skin types, and extrafacial sites such as upper lip, neck, chest you can use it. But the serial applications is required. Most recently 40% mandelic acid, and the older ones are 10 to 30 salicylic acid, 20 to 70% glycolic acid, gestnate, solid carbon dioxide plus, and TCA less than 20% are under these categories. So coming to the glycolic acid peel, this is the most commonest one in the first line. Here the neutralization is required. I have put this slide to only differentiate all the superficial peels. And reacetylisation is mostly 7 to 10 days required. In lactic acid peel, here it is the low concentrations is useful. So it is you can use in lower concentration compared to glycolic acid. In mandelic acid peel, it is the uniform penetration through the lipid-rich area is there because it is lipid soluble. But 3 to 5 repetitions is required, so repeated applications is mandatory in mandelic acid. In salicylic acid, the common indications is acne vulgaris, but it is interesting that it is having a self-neutralizing effect, so no need to give a neutralizer. But it is easy, rapid and deep penetrating through the lipid barriers of the epidermis, 30% salicylic acid, mostly we are using it, acne vulgaris. Next coming to the pyruvic acid, it is having hydrophilic nature. So it is having the activity against like salicylic acid and glycolic acid. Next coming to the medium depth peels, it is extensive protein precipitations it causes resulting in coagulative necrosis and mostly TCA 35 to 50% as discussed by the already presented by Dr. Aditi, and TCA combined 30% combined with glycolic acid 70%, gestnate and the solid carbon dioxide. So that's the other examples. Just coming to the deep peel, this is here the whatever something which goes up to deep up to 600 micrometer. So they natures the epidermal keratin and dermal proteins causing complete epidermal lysis and mid-dermal injury. Single session is required unlike your other peels. Peeling occurs in 4 phases like your inflammation, coagulation, reepitheliation and fibrosis. Reepitheliation mostly occurs in 2 weeks, but the erythema persists up to 3 months. Most examples are TCA 50%, more than 50% Becker formula. Then multiple lead applications 20 to 40% salicylic acid and pyruvic acid are the examples. So Becker phenol having occluded and non-occluded method. In occluded method you can occlude the waterproof dressing, petroleum jelly you can use. In unoccluded method applications of more peels. So now this what happens, the deep peel is having erythema, it persists for 3 months, it is having complications, side effects. So nowadays the lasers has largely replaced these deep chemical peels because of having improved control of ablative depth, their ease of use and their relative lack of systemic toxicity and side effects. So level of frosting, as I have told, in peel, superficial and medium and deep peel, we have to achieve the frosting intensity, that is the end point, to 1, 2 and 3. In superficial, frosting may be speckled or speckled white frost like mild erythema, but in medium you have to come to the end point even white frost, not the patchy white. And in deep you have to find out that is there any solid white frost is there or not. Next comes your general principle, how to approach. So, as the clinical cases, just like the clinical cases, in every dermatological procedure, you have to take the history. Our teachers have learned us that history is an important part, but we are skipping that one. So, for this reason, we could not say that this peel is effective to that person or not. History is very important, so we have to take the history regarding the comorbidities, surface infections, carrying fluid formations, any prior therapy, X-ray, radiation, and whether the patient has undergone any facial surgery or not. Then concomitant dermatological condition, but the medication history is very important, like your institutional therapy, hormonal agents, and contraceptive pills. Patient lifestyle and pregnancy practices. But the central part here is that the motivations of the patient, if an expectation. Whatever field you use, for the important part is expectation. If the patient is not satisfied, then your treatment is not complete. So expectation, but what is the expectations the patient is very important. Then comes your examination part. You have to examine the phototype of the patient, the skin type and the skin color. Regarding the skin color, you can test the taste spot testing is there. I will discuss about this. Then the degree of photoaging according to the Gauss classifications. Then the about the pilosurfaces, you can, if all the physical type is very good in for the superficial peel, but fair complexion blue-eyed female is good for the deep and medium peel, but in case of respective 3 to 6, we have to be very careful. And male skin is having thicker and coarser and more oleaginous skin, so it should be very careful about that one. Next, what is the taste spot testing? It is controversial, but the sites were lateral temple, anterior hairline, and periauricular. Here the advantage is that you can calculate the amount of peel or more accurate predictions of the peel efficacy and healing time, and the pigmental response and post-peel complications is there. But the problem is that most of the time there will be the delay in the treatment and misrepresentation results in the persistence of the taste spot until the definitive procedure takes place. What are the pre-peel caps? Well, you are doing the priming. So what helps in priming? What is the advantage of that? Enhances the patient compliance, decreases the intolerance and reduces the risk of complications with the PIH. It keeps the starting cutting. So pre-treatment should be started 2 to 4 weeks before the chemical peel, and it should be stopped 3 to 5 days prior. Broad spectrum sunscreen should be applied before 3 months. And what are the pre-treatments available? Retinol like 0.025% to 0.05%. It helps in cleaning of epithelium and reepithelium. Hydroquinone 2 to 4% cream. Then glycolic acid 5 to 10, and salicylic acid 5 to 10%, and kojic acid 1 to 4%, and azelaic acid. Finally, the topical corticosteroid. All these are the priming agents that you can use in the pre-treatment procedure. Next, ask the patient to avoid waxing, and electrolysis and dermabrasion should be avoided 3 to 4 weeks before treatment. These are preparations. So the day prior to the peeling, wash with non-residue soap and refrain from the using moisturizing makeup as the patient to do this. On the day of the procedure, wash their skin with a non-residue cleanser. The patient should not use jewelry and contact lenses, and degrease the area with acetone and isopropyl alcohol. So room should be appropriate. The room should be with appropriate lighting, adequate ventilation, and access to resuscitation equipment, and assistance should be there. Blood tears from the medial canthal regions to prevent backtracking of the peel, agents into the eye. Patient not left alone during the procedure. Most of the time we are applying the peel and going outside. At the site of separate, the peeling agent should be checked separately and poured into a small clearly labeled glass receptacle. Remove any crystal if is there, and securely it should be stored securely. Next is never pass across the face. Sometimes we are using tape, having the peeling and crossing the patient across that one. It may speed up the patient. Neutralizing agent and eye irritation solution should be available, readily available there. And throughout the procedure, gloves should be used. And the positioning of the patient should be done. It should be done at the 45 degree, and towel should be wrapped around the neck, and eye shielding should be done. A surgical cap or headband should be used. Petulanum and zinc oxide paste should be used. Superficial peel generally do not require any anesthesia. Then the deep peel. So these are the red areas showing the denser area. You should be very careful on these areas, and the blue circles and the blue areas showing the basic cosmetics of units. So you should start the peeling over those areas first. Then application technique. First of all, if you are having the liquid products, then you can use the broad cotton tip applicator cotton gauze swab. If it is having the gels, then you can use the wooden spatula. Chemical peeling should be start on the thicker area from just like the Aditi had told already, forehead, cheeks and nose and chin will be treated fast, followed by periorbital and perioral skin. The peeling agent should be applied in an upward direction with a firm, even strokes and extended beyond the vermilion border and into the oral cavity. Avoid, the important part here is the skip areas. So avoid overlapping brush strokes and the skipping areas. The feathering technique should be applied. The edge should not be abruptly stopped. It should be just, the technique should be used to avoid the sharp demarcation line. Deep wrinkling area, stretch the skin and do it and let it dry, and after that leave the area. A bland emollient until the peeling is complete should be used. So what are the post-peel care? Good post-peel care ensures the prompt recovery of the skin and prevents unwanted complications. Wash their face with a non-soap cleanser. Avoid rubbing, scrubbing, all these things. Apply a bland emollient until the peeling is complete. If the patient has, if you note in the following days, then ask the patient to apply topical agents. And makeup may be applied after re-epitheliasis. Then sun avoidance and daily applications of the sunscreen is good. As the re-epitheliation days, I have told 7 to 10 days, 5 days, all these things. So ask the patient according to that, apply the makeup after 5 or 7 days. So what are the complications? As we know, minor complications like just in the hours or minutes you may get, like irritations, burning, erythema, pruritus, all these things. And over the days, patient may complain you as acneiform eruption, infection, persistent erythema, and your demarcations line, milia, all these things, and you have to treat accordingly, seeing the adverse effect. What are the major? Mostly major there is rare, but allergic reactions, laryngeal edema, TSS, cardiotoxicity, mostly after using this salicylic acid pill salicylate. And if absorption occurs, then it may cause acute kidney injury. Lower lead retractions, corneal damage also can be there. So you have to treat accordingly by sending to the plastic surgeons. So what are the take-home messages here? The chemical peels is the third most commonly performed non-invasive cosmetic procedure in the US. So it's mostly the indications is 4 categories, just like your chrono and photoaging and acne and acneiform eruptions and dyspigmentations in pre-malignant epidermal neoplasm. Now the scenario is that just like the deep pills is just replacing with the lasers. So but the superficial pills popularity is still there, and it is having the product diversity, so many products are there, and so it is should be individualized. You have to apply those patients and see whether the response is coming or not. So appropriate medications with proper technique and excellent clinical efficacy and cost-effective tool. Thank you.
तो स्क्रीन में क्या लिखा नहीं देख पा रहा है, क्लैरिटी नहीं है उसमें. अच्छा.
Hello. Now,
वर्डिंग्स नहीं देख रहा कुछ.
Dr. Shastika.
Okay. देख लीजिए आप उसका, ठीक है.
Speaking about moisturizers in various dermatoses.
के लोकेंद्र, डॉक्टर के लोकेंद्र.
Good morning. I'm Dr. Swastika, and today I'll be speaking on moisturizers in various dermatoses. Now, moisturizers, one of the most commonly prescribed cosmeceuticals in the prescription. Moisturizers are one of the most commonly prescribed cosmeceuticals on our prescriptions as a dermatologist. So today would be related to introduction, the categories of moisturizers, ingredients, functions, and therapeutic use in various dermatoses. So the term, this moisturizer was in fact a term that was promoted by marketers, the Madison Avenue marketers, promoting the facile idea that they do moisten the skin. But if you go for the definition as a cosmetic preparation that is used for protecting, lubricating, and moisturizing the skin. So as for the classes of moisturizers, they are divided into 4 classes: emollients, humectants, occlusives, and protein rejuvenators. Now, emollients are those that improve the skin barrier function, membrane fluidity, and help in cell signaling. They are used for a routine skin care, for tackling dry, rough skin, and for the papilloscomal skin disorder. Humectants are those which attract water either from the atmosphere or from the dermis into the epidermis. So they are basically for ecthyosis. Occlusives, they form a layer on the skin and they prevent the transepidermal water loss. So depending on that, they are used for prevention of contact dermatitis or atopic dermatitis. Now, protein rejuvenators, they are used in cases of photodamaged skin and skin rejuvenation. The contents are mainly collagen and elastin, and they are used for replenishing the skin's essential proteins. So these are the pictorial description of the same. The occlusive agents would form a kind of layer and would prevent the water loss from the skin. Humectants which attract water from the environment within the skin, and emollients in turn add hydration into the skin. Now, as we speak of the ingredients and what would be the correct method of applying a moisturizer, we hardly speak so much to a patient to explain how he or she should be applying the moisturizer, how many times they should be applying. So as for the ingredients, they do contain emulsifiers. Whenever you're mixing oil and water, of course the tendency is to separate. You need an emulsifying agent that are generally in the form of detergents. So an emulsifying agents are required. Moisturizing agents, as we just saw. Some sensory modifiers and preservatives are added to tackle any microbes that may have come in during the packing of these ingredients or manufacturing. As we speak of special additives, these are used more for marketing, especially the botanical agents. The one which we know commonly is aloe vera, is an overhyped thing, but when you go for the evidence-based literature, it hardly has any moisturizing effect. It's more for the marketing thing. It more has an effect more on, it has some anti-inflammatory and has effect on wound healing, but very minimal moisturizing effect. But aloe vera, if you see, that would be making up the content of most of the moisturizers. Vitamins are added, vitamin A, E and C. Some antioxidants are added. Lipids, fragrance, of course, to enhance the acceptability from the consumers. Nowadays, sunscreens are being incorporated. That is again an in thing in the moisturizers. And any moisturizer would be generally a combination of emollient, occlusive and humectant, all 3. So what should be the ideal way of applying a moisturizer except for occlusives? It should ideally be applied on slightly moist skin. So immediately after bathing or after rubbing a wet cloth. The moisturizer should ideally be put in both the palms and should be applied along the hair follicles. It should not be vigorously rubbed as there are chances of folliculitis. And there are studies which say that after 8 hours, only 50% of the moisturizer is retained on the skin surface. So that is why we ask the patient to apply the moisturizer almost 1 to 3, the frequency should vary between 1 to 3 times daily. Now these are the different humectants that would attract water. The common ones which we know, they are added to moisturizers are glycerin, alpha hydroxyl acids, sorbitol, honey. This is a long list. As for different classes of occlusives, which would prevent, kind of occlusion and prevent the transepidermal water loss, There are hydrocarbons, various fatty acids, sterols, and wax esters. Now, emollients are classified into 4 kinds. They might be dry, fatty, astringent, or protective emollients. Protective emollients could be diisopropyl dialinoate or isopropyl isostearate. Now, what would make an ideal moisturizer? That is the question that comes to our mind often. We are still in search for that. So something which would prevent or reduce the transepidermal water loss, that restore the skin lipid barrier, duplicating and enhancing the skin moisturization. Should be hypoallergenic, because frequently we prescribe it to patients with atopy. That is very important. Non-sensitizing, fragrance-free. Should be immediately absorbed. You don't need to rub it for long. Provide immediate hydration. And of course, should be cosmetically acceptable to us. So what are the functions of moisturizer? We know of only one function that comes to our mind when we speak of moisturizer. It's lubrication. Of course, when you lubricate the skin, it reduces the fine lines, hydrates the skin, and improves the barrier function. Other than that, moisturizer has some other functions also because of the additives that it has. It does serve some anti-inflammatory action, some anti-pruritic action it has. It blocks the COX pathway. Because of the mineral oil added to it, many of them, it has a very low-grade antimitotic activity that would be helpful in cases of psoriasis. Sunscreens are being added these days, so it would protect from sun. Of course, some agents that would help in wound healing, like aloe vera. Now, moisturizers come in various formulations. They come as lotions, creams, ointment or gel. Now, depending on your needs and your body surface area, you choose the exact kind of formulation. Lotion generally comes in an oil and water formulation. It's non-greasy, easy to spread, and is generally used as a daytime moisturizer for the face and the body. It's also used as aftershave lotions. Now, creams are a little thicker, used as a nighttime moisturizer for the face, hands, and the non-hairy body parts. For the hairy body parts, we prefer the lotion. That also comes in a water and oil or oil and water form. The ointments are a little greasy, and you would they are especially useful in places with low humidity. You use it especially when a very high degree of occlusion is required. And they are not supposed to be used for intertriginous areas. There they are contraindicated, but that would form a big, thick occlusive layer. Now gels, these are again used in the intertriginous area. These are easily absorbed and also do find a high rate of acceptance for the face because they are non-comedogenic. As you see, different formulations are for different skin types. For a very dry skin, an ointment might be preferred. For a relatively greasy skin and a normal skin, a cream might be preferred. And a very greasy skin, large or hairy areas, as we see, a lotion is preferred. So what could be the adverse effects? Subjective irritation. Some patients might be sensitive to some particular ingredients. There's a plethora of ingredients that is active in a moisturizer. There can be subjective irritation. Allergic contact dermatitis, occlusive folliculitis, cause preparation over a dry moisturizer can cause occlusive folliculitis. Some photosensitive eruption. Cosmetic technique, we are not using the right kind, the right way formulation for your skin type. Can be what we use for moisturizers in various conditions in dermatology, we know first comes from eczema, atopic dermatitis, hand eczema, nodular dermatitis, all disorders of keratinization like psoriasis, keratosis pilaris, any dermatosis that is against to some underlying disorders like diabetes and atopic dermatitis, other disorders like acne, rosacea. Here, of course, the kind of moisturizer, the formulation would differ depending on your skin type. For acne, you have slightly thinner preparations as compared to a dry skin type. Then you also use it for skin care in some special population like the neonates and infants who have a weak skin barrier, the elderly patients, miscellaneous uses are for xerosis, and of course some anti-aging products are now being added that is also used. So what is the role of emollients in atopic dermatitis? That's the most important indication when we speak of. So the most important step in fighting atopy is rehydration. And the principal mode of action of emollients is to improve the lipid barrier of the skin, thus reducing the transepidermal water loss. So there are studies which have proved that moisturizers would reduce eczema flare-up and would ultimately reduce the need of topical steroids in these patients. So this has been taken up from, adapted from Aesthetica. This was a figure that was present. And this is a therapeutic ladder that has been suggested for the management of patients of atopic dermatitis. So the step one, whenever you have dry skin on a normal appearing skin, step one is hydration of the skin. After bathing, you apply moisturizers. That is the basic step. And you climb up the therapeutic ladder as the severity goes on increasing. But whenever you step down, moisturizers at every step are required, and you keep on adding other topical or oral agents for the management. So what should the prescribed volume? That again is the thing we get in our patients. How much moisturizer? So that the number, again the amount is large. It's around 250 to 500 grams per week for children. We speak of for patients of atopy. So this would be about 2 to 500 gram dispensers per month. For adults, it would be around 600 grams per week. So that would be make up about 500 gram dispensers per month. That is the huge amount which patients do not apply and come to us, and that's why the problem is not solved many a time. So pump dispensers are a good way to help patients. We should always be educating them about the right amount and the correct volume to be applied. And we can illustrate it to the patient how much moisturizers or emollients they should be applying at one time. And at one time, most pumps approximately dispense about 4 grams. So this again is the suggested moisturizer for the skin type, depending on, in atopics, depending upon the skin type. For a normal skin, when the patient is in remission, the kind of emollient, it should be emollient dominant. Normal to dry skin, it should be humectant, light duty, like glycerine, sodium lactate. For dry but non-inflamed skin, you can go for occlusives like mineral oil and petrolatum. And for dry and inflamed skin, there are some skin protectant drugs like colloidal oatmeal, a blend of emollients, occlusives and humectants, along with anti-inflammatory and antimicrobials. And this is the evidence that is there. Yeah. So what exactly is the efficacy of emollients in atopic dermatitis? There have been few studies. I could find one study in infants which says that infants with moderate to severe eczema found that using emollients significantly decreased the requirement for topical steroids. We need to have more evidence-based study for the use of moisturizers. So this contact dermatitis is a frequent problem with moisturizers, especially patients with contact dermatitis is one of the indications we do use moisturizers, and frequent moisturizer application. The moisturizer should be bland, would help improve the skin barrier. This is another indication, nubular dermatitis. In between the episodes, intensive moisturizations may help decrease the flare frequency, and ointments are more effective. So to conclude, our need for moisturizer is likely to increase in future as we urbanize. The incidence of dry skin keeps on increasing, and the ability to tailor agents to specific our needs will be critical in the future moisturizer therapy. So we may and the baby moisturizer has been focused and flourishing. Thank you.
Thank you all the speakers and representatives for conducting the session on time. I request faculties of the session to kindly receive memento. I request Dr. C.S. Sitkasan to kindly felicitate the faculty. Now we to the next session, which is on vitiligo. We have our chairpersons. I would like to request our esteemed chairperson, Professor Dr. Gurmohan Singh sir, to kindly come onto the stage, and Dr. A.K. Srivastava sir to kindly come onto the stage for chair the session.
Good afternoon. Thank you very much for giving me the opportunity to be here. And this session, which is, so I invite Dr. C.R. Srinivas, one of the most eminent dermatologists, and I know him and have followed him. I think right from the day he became dermatologist. So, please, to talk about years, decades, Dr. Srinivas. At a ground level, at a critical level, in all aspects, not only the academic, not only the medical, but also the social and economic aspects of the patient. Let's listen to this excellent talk.
It is indeed an honor to have Dr. Gurmohan Singh chair this session. He was my examiner during my MD exam, and he was also the boss of Dr. R.P.C. Nayak. R.P.C. Nayak was my boss at Manipal, and much of vitiligo I learned was from R.P.C. Nayak. So indirectly, I have learned about vitiligo from you, sir. So it is definitely an honor, and today I am going to share on how I treat vitiligo. And each person, will have your own. So you don't have to do exactly what I say. So you have to do certain things. Like I'm not going to expand too much because time is short. You will have to be very silent. You have to let the person talk. You have to assess what the patient expects. The vitiligo patients, some of them want arrest. You have to arrest that. The history of dual is very important. Rapidly is much more dangerous, and you will have to treat that more aggressively. That is spreading very slowly. You can go little easy on that. History of comorbidity is very important. Whether to give steroids or other drugs, that is very extremely important. Examination of the type of vitiligo is very important because the acral type of vitiligo you all know well that responds poorly. The segmental is often stable, and the vitiligo vulgaris sometimes you can even get the mixed type of vitiligo. So you will have to determine the stability. Stability determination is a tough ask because some will tell but I need but. So the best is for you to take 3 months to find out whether it is or not. Take a photograph, give it to the patient, or keep the photograph and see whether it is spreading or not. Don't rely on the word, especially the finer amount of spread the patient will not know. Then of course, where the patient occupation is important, we are going child, whether they can expose. There is no use giving 2 tablets of melanocyl and exposed to sunlight because the person will be in school when the sun is there. So you will have to find out whether is there a rooftop, is there privacy on the rooftop, evening exposure is it better, morning exposure is it better. All this you will have to assess when you are giving phototherapy, because unless you do that, the patient is not going to follow. Then of course counseling as to what should be the expectation, and then the treatment aspect comes in. So these are the things which I told you. I said silent attentive observation, assessing patient's expectation, evolution, comorbidities, type, evolution, determining stability, location, ability to spend time, money, all those. Mentally planning the patient for the most suited approach. So you have to buy time. You have to tell them that it's going to take a lot of time, nothing is going to happen. So you have to buy a lot of time for the treatment. For all dermatologic disease, buying time is extremely important. Time permitting, I will tell you a story about time. Then counseling is, I told you, extremely important. So what is the treatment available? Stabilize the disease first. For stabilization, first of all, to determine whether it is stable or not. So buy time, take about 3 months in case you are in doubt. Try for the simplest treatment, antioxidants. I don't know whether it stabilizes or not. It buys you time. And why time is so important? A man was sentenced to death by a king. And he said, sir, give me 3 months time. I'll make my horse walk the rope that is tied at the top. Then they asked, wait, okay, the king says, 3 महीना में इतना बड़ा देखूंगा मैं, घोड़ा चलेगा रस्सी के ऊपर, ठीक है, take 3 months, उसके बाद तुमको मार देंगे. Then they come and ask, भाई क्या होगा तुम्हारा तो 2-3 महीने के बाद मरना है, तुम जानते हो कि घोड़ा तो चल नहीं पाएगा. बोला भाई 3 महीना में lot of things can happen. I may die naturally, the king may die naturally, or for all you know the horse may walk the rope. So buying time is extremely important while for all things of in dermatology. Camouflage is by far one of the best suited treatment for the thing, and you will have to sell it aggressively because many patients are not willing to buy the camouflage. So antioxidants often they may stabilize. So I give antioxidants and tell them for about 2-3 months to find out whether it is stable or not. Camouflage is extremely important. Do counsel. There are certain indigenous, like our Dr. Sugadan had come up with Basma, Suvarnakarini and all. And we have also worked with camouflage. See, this is a hair, soaked in henna, orange hua, uske baad indigo mein karo, black hoga. So even for hair dye, you can use it for skin also. This is the camouflage which we have used. And the advantage of this camouflage is, pani se dhulta nahi hai. Even otherwise, even henna as a camouflage is wonderful because the other camouflage is going to get rubbed off. So henna लगाने से वो पीछे का orange कम नजर आएगा. So it is you have got a background which is not white. You have got a background which is orange. Above that, if you put the skin color, even if it goes off, the orange gets exposed and the white does not get exposed. And if you put indigo on it on the next day, you get a black color also. We have to standardize as to how this is being done, and we are conducting studies on that. Topical steroids, you know well, is a double-edged sword. Arrest भी करता है, white भी करता है. So you should know how to use it, and I don't have to tell you how to use topical steroid. I'm sure you are masters of that. Tacrolimus and pimecrolimus are the new drugs. It can be used mostly on the face. Other areas it does not penetrate well. If you want it to penetrate, either use occlusion or use salicylic acid and then apply this to increase the penetration. Otherwise, using this costly molecule on acral area day in and day out for 6 months together is an absolute crime, and you will not be pardoned for that. Pimecrolimus a person cannot tolerate. Decapeptides are available. You could try that. I don't find it awfully helpful. Then of course Udicolog application, which you can put 9 drops of Udicolog and 1 drop of Sorelin, 8 ml solution, and apply that. And then export. But disadvantage is that it will evaporate very fast. So every time you have to make this solution. It can be used for topical. So we came up with what is known as a soap. So what we do is we take 1 ml of the 8 ml solution and mix it with 9 ml of liquid soap. It becomes 1 in 10 solution. 1 ml with 19 ml becomes 1 in 20 solution. So इसमें क्या होता है 1 ml with 39 ml becomes 1 in 40. So this can be applied on the skin before the exposure for 5 to 10 minutes. Then you can go on increasing the strength by going from 1 in 60 to 1 in 40, 1 in 30. You can make it stronger as time passes by. So person applies this on the skin, waits for 5 or 10 minutes, washes away. इसमें क्या होता है advantage क्या होता है? There is hydration of the skin. This thing, because the whole thing is in soap, you don't need a soap. So hydration increases the penetration to ultraviolet light, and then they can expose. And because it is diluted, you are able to expose the person comfortably. So this is an effective way to deliver phototherapy. Bath suit we have tried. Bath water we have tried. They are expensive. You can also use the other ways of delivery. So this is some of the effects on the soap poor. I call it as soap poor. We can use phototherapy chambers. Light treatment is available. This is the targeted light. We can use targeted light for short areas. And if you want to use the targeted light for larger areas, you can use the comb that is used for the scalp. With the comb, you can cover larger areas of vitiligo. So the number of shots come down and it becomes cheaper for the patient. Sorry. The other, we know that immunosuppressant, methotrexate, azathioprine, MMF, these are the things. Azathioprine, as rightly said today by Srivastav, I am afraid of that drug. And even if you do TPMT, then also there can be problem. But if you still want to give azathioprine, start with 25 milligram, wait for some time, do the blood test, increase by 25 milligram, wait for some time, do the blood test. So go step by step with azathioprine, then you may not get a problem. Methotrexate, we know how to handle that. MMF is an expensive molecule, which only partially. Then of course then cocktail therapy. What is happening is people are coming from very far off places. And how to give them phototherapy, how to do procedures for them. So for that now we have come up with what is known as a compressed therapy. यानी कि सब treatments को एक ही time में at larger intervals you can give. And this is the present studies we are at present conducting. So therapy इसमें तुम्हारा होता है visits, time, cost, all this. So we cocktail therapy. What is this cocktail? So when a person can be called once in 15 days or once a month, at that time we give phototherapy. Phototherapy karke at the same time you can occlude, we can do CO2 laser on him, and then you can apply the PRP, platelet rich factor. All this can be done at monthly intervals or at 20 days intervals. So by that you find that this is how we did the PRP. And these are some of the results after 4 sessions of fractional laser and 2 weekly intervals of thing with PRP. This also. So the treatment becomes a little fast forward and the number of visits for the patient comes down. And in one visit we carry out all the procedures when the person comes. So you can see the effect of the phototherapy. The settings are there. And here we apply tricot rather than giving the small areas. We prefer to go for a injection tricot because taking the PRP for a small area becomes awfully difficult. But when larger areas are there, PRP might be a better option. So this is the same patient, good improvement, same patient, leg no improvement. So vitiligo is a very funny disease. Same treatment, some areas will respond well, some areas will not respond well. So all this you will have to tell to the patient when you are treating the patient. So the leg there was no improvement. Here you can see after 1 lesion of targeted phototherapy and topical application of tricot after fractional CO2, we were able to get the results. 4 sessions of targeted phototherapy, then fractional CO2 laser and topical application of triamcinolone. Why triamcinolone? Because triamcinolone has got a depot action and if it goes in, it is likely to stay for a longer time. So it is as good as giving intralesional triamcinolone. So this combination we have been doing this for treatment. You can see the results. Even the leg also we are able to get results with this. Lateral aspect of the right foot, even the heel area has shown pigmentation, which usually does not show pigmentation. In the lips we are able to get in, even the lips you can do the same treatment. So it is no magic, but this cocktail therapy is something which we offer for persons who come up from other treatments. You all know, this is the only new thing I thought I would add. Sopua and the cocktail therapy, wherein all the treatments can be done in a single go when the patient comes and can come only at longer intervals. Thank you very much.
Wonderful talk, Dr. Srinivas. Any question? Yes, Dr. Bose.
What is going on crisabiol, topical therapy, oral. They have other JAK inhibitors they are using in very difficult cases, but they find tofacitinib to be better than MMF and others. But even tofacitinib resistant cases, they are using certain other new molecules in the same JAK group, and they are finding good results. But we had a discussion in JAD, and they approved that in India we have tofacitinib, crisabiol and phototherapy, so we can combine them, and within 3 minutes to 6 months you have a proper whole body repigmentation seen. The trial is going on. I think the first phase is already started in Chandigarh. Let's see the result.
Sir, that tricod injection, you are applying the
Yeah. 40 milligram ka. After doing, instead of applying the Dexone or that is liquid, I applied this because it has got a depot action. So,
Can I just add that very recently Dr. Mukhtar in Bihar has published an article on how he treats lip vitiligo, which in my practice I find very resistant and difficult in the absence of having a laser. So he suggests that you apply undiluted trichloroacetic acid to the lip, let it crust, let it wound, and then when the crust falls off, you get pigmentation. To be honest, I was very wary to begin with, but then I thought I'll give it a shot because I had a couple of patients who were very resistant, and lo and behold, I actually have pictures on my phone. Maybe later I'll share it with you and show you the results. And 15 days later, the patient had pigmented up to 60 or 70% with a single application of undiluted trichloroacetic acid.
it also happens that if a person applies 8 mop and he develops a blister, and the blister phototoxic blister, sometimes when the phototoxic blister goes off, that area pigments, but it is extremely unpredictable. If the person's vitiligo is active, then it is likely that the vitiligo is likely to worsen.
No, this is for those patients who you've sorted out most of it, but you're stuck with the lip, and because it's something that is so obvious.
So what I would suggest, if you're going to do such a treatment, try it over a small area first.
Yes.
Find out if that area pigments and then try over a large area.
Sure enough.
Yes, please.
Hello. Yeah. Dr. Srinivas, I entirely agree. CO2 laser is very useful. Even I am using for the last 8-9 years. It's very useful. But I want to see, I did not see any single patient with complete subsidence.
अभी तो शुरू किया ना, खेल अभी शुरू हुआ है, और लेजर पेशेंट is hardly about 7 months old. तो हम लोग तो बॉम्बे में नहीं है लेजर खरीदने में बहुत तकलीफ होता है.
Because partial improvement we have seen with.
Yeah, it is on 4 sessions, 3 sessions.
Yes, same thing.
हाँ सर.
It's
Therapeutic wounding which is working. Therapeutic wounding.
Therapeutic wounding is working.
It's such a wide subject that it may take days together to discuss and understand the experience of people, and this varies from one to the other. But well, I may tell because I see also a lot of UP and Bihar and so much that sometimes I I see a limited number of 25 patients in the day. So sometimes I feel, is it a dermatology clinic or vitiligo clinic? So more than 50% patients of vitiligo. And this is why it's so difficult to handle. So everyone has a different approach, but I believe still that there are two basic principles for me. Is it stable or it's a progressive? If it's stable, then I don't give any immunosuppressive or steroids, even if one may say there is some local or the other stable, but the side effects are more than we have to weigh. Then if it is, what is the question of definition of stable? You read any literature, Pasricha said 2 years. Oh, which patient is going to wait for 2 years to stable? That means every patient should be given no liens for last 2 stable. So one has to have your own criteria that what is stability mean according to your population. So when we consider four months as stable, if the patient has no increase in the size, but patients are so tense that whenever they come, no, this has increased a slight. So we ask them to keep a record of photograph. Again, photographic record, what does it mean? It only shows the configuration, not the size. So my nursing assistant explains that how to put the scales and then measure and take all photographs. Still, let's say one way. So the progress is one side, there is management. For management and phototherapy still stands the test of time. It is for years. Then there was a melody. So phototherapy using UV nerve or what light from the sun. So this phototherapy is still stand. It is the art here. Phototherapy we say is not good or something is better. But question is in dermatology, particularly in the treatment of vitiligo, it is art. Art is how much light to be given. Everyone can't go to have from the villages as we are getting to have the chambers and coming, whatever method it may be. The art lies in the quantity of ultraviolet light, how much to give. So this will, we can't have the dosimeter for every patient. So we have put a criteria that when you see if a patient comes fresh and has a criteria, a baby pink color, it should not be red, tomato red, it should not itch. That should be your optimum. Continue with that. If at any time the ultraviolet index is very high, no need to look into your Google. Today you can look into your Google and see the UV index at any time. But that is a UV index gross, not for UVA or UVB. Anyhow, criteria is best to see the response. And so that's how we give. Either you are giving UVB and B. Then we've started the home therapy because it's not possible to go to all that. These tubes are available for long. My patients, I think 50 years are getting previously Sylvania from America, nowadays Philips imported come. And so these tube lights, we adjust them, the nursing assistant knows how to explain what should be the distance. And sometimes they bring so close and produce a distance. Sometimes it's far off, then there's hardly any effect. So that criteria has to be explained. This is difficult because dermatologists don't have time. So the nursing assistants or nurse should be explained to spend 10 minutes at least. Then even after that, when they come back, there is something wrong. So again, when you are using a topical Puvasol, how to apply it? If applies the swab, it spreads all around and produces more titanium. And if it is a small lesion, so we explain them simple practical methods. Have a matchstick. If it is a small spot, matchstick is naturally a wooden, so it will absorb some of your solution and apply on that spot. If it is a bigger spot, get an earbud and apply with that. So you have to apply them. I tell them that it's like an art, artistically applied. It should not go much beyond that. Of course, the pigment has to come from the border, but there is 1 millimeter harder. So even if you limit up to that patch, it will extend to the side. So these are the two basic principles. Then, of course, as I said, the antioxidants and they have role. But I read one paper, I heard that one person said that they can only treat 95% of the patients by giving the antioxidants. I doubt that. There's many sort of publications you have to scrutinize. Well, that means there are some effects, so I also start giving, because question is affordability. You don't put a load on the burden that he sells as this. Then the third example that I'm trying to add, I'm taking more time than the speaker, but another important point is the cost to the patient. Cost to the patient is only not your Sorelins, but it's also his travel from the village, accompanying patient usually, losing his salary or above. That has to be counted. So I don't call the patient, explain them well, repeat them. The pharmacists around, I don't have my own pharmacist as many practicing people have. So I train them, pharmacists and their assistants, the delicacies of these applications, and then ask them to come after 4 months. Try to call them before 4 months. I don't expect them. So I 3 to 4 months afterwards. And again, a very important thing, we tell them we must prognosticate to them. It's not only we counsel them, but prognosticating is very important. If there's a small lesion, who says, tell patient got well, there's a small lesion, early lesion. I give them example, an early cancer can be cured and advanced cancer can lead to death. So once you come with 25% of the body surface affected, what do you expect? So the prognosticate we can try to stop the progress, but only there will be a slight regression if at all possible. Also tell them palms, shoulders, lips are difficult. So these are important things on the first visit. And then the most time that they take, waste your time is खाना कौन सा खाएं, कौन सी चीज मना खाएं, मीट नहीं खाएं, मीठा. So we start with them that this is vitiligo and it has no relation with diet. Whatever you want to take, you can take. It's not contagious. To remove the stigma, I always say it's non-genetic. Because if it is a multifactorial, genetic factor is hardly a very small contribution. So don't confuse them with consequence, because that's a major cause of stigma. And then luckily, Brigadier Manas is sitting here. So I want to bring one point in attention which I have been bringing to many generals. One of my class fellows was the Director General of the Armed Forces, Dr. Rai, Kuldeep Rai, so he might be knowing. I asked him, he was my class fellow in MBBS. So I asked him that why the hell you, on one hand you celebrate the Vitiligo Day in June such and such. What the hell we do when we cannot convince the army officers that this is not a contagious disease? Why do you reject them? All right, even if they get a small patch, they reject them. And I feel, I've asked colleagues that why don't you try to bring it up, discuss among yourself, army people, when they have their own association, that they should discuss it, because this is our problem. There is no 1 month goes when person comes around rejected for this small patch. So then when I asked to Roy, he said, I will discuss because he's at you, I don't know what his specialty. He was retired when I talked to him. Then I asked another general. He said, well, he has given an answer which sometimes one can suit. He says, when you admit in medical grade, why you consider the most intellectual person, the best medical person who has intellect? Similarly, we want the best health. That means, I said, you recognize leukoderma as a physical health, which will harm your army work. There's no answer.
Yes, I think I'll respond to that. I have responded to that actually in some other fora, but I'll sort of respond to that. You see, sir, the problem is we have to understand that somebody in the army doesn't work like somebody in civil. It's got nothing to do with infection at all. Now let us say I've got a facial vitiligo. I'm posted in Ladakh. I'm, let's say, posted in northern Glacier, in Garwan. I worked there. Now the problem is that in winter, suppose, you see, ultraviolet intensity is much higher. His problem is going to be photosensitivity. He is going to have, his problem is, vitiligo itself is not the issue. The issue is that once he gets a red face, he will have to go to a dermatologist.
Now, once the passes are closed, the nearest time he will be able to go to a dermatologist is 4 months. He cannot go to a dermatologist before that. Now, the issue which he will face is that he is going to be getting stuck there, and he will require regular care. The problem is that suppose he is in that Galwan valley, he is not going to be relieved before 3 months. Suppose he is in Kargil, one of those posts. Those posts are winter cut off. For 9 months, he is sitting in the post, he cannot come down. So the situation is very different. So if he has photosynthesis, he has a problem. So let me complete. He has a problem. He is not going to be able to access a doctor of any sort. Forget about a dermatologist. He is not going to be able to access any doctor. He is in a post where there are 9 soldiers. A lot of times we do not realize the kind of limitations under which we work. So the problem is any condition which can require. Now suppose let us see he's got vitiligo of the scrotum, he's fit. There is no problem because the same issues which are there in vitiligo of the face or vitiligo of the arms are not there if he's, let's say, has a segmental vitiligo involving the scrotum. Because there is none of these factors are applicable and they are fit. So the issue is that any person who requires any kind of long-term care and who might require any long-term care, in a civil situation, you don't care because he can come, take some treatment and go. But the problem is in a winter cut-off, let's say in Siachen, he is cut off for a period of months, he's 8-9 months. What is he going to do? So that is the basic problem. So vitiligo in itself is never an issue. It's got nothing to do with infection at all.
Wonderful, Brigadier. But question is, a person having a half a centimeter diameter patch on the buttock is rejected, presuming that he will get
No. Now I tell you, sir, you will know very well.
They have rejected, I have seen many.
We will, I tell you, the issue is
likelihood of accident. Not imagining, because he has one patch, ruining the life of that person, because there is a 1% or 0.1% chance of his getting. What is your...
I will just give you one little example. You know, disabled people. Now suppose getting disabled people into government employment, you know, in other government services is considered a credit that you have disabled people who are being given employed. Now the problem is in the armed forces, if suppose you hear in the newspaper that 20% of the armed forces has got disabled, will you like it? That is the problem.
Manas and Dr. Gurmohan Singh, I think we are getting late. We can.
Once he develops on the extensive path, or discharge him.
No. Then he'll have to be given disability pension. I look after disability pension in the office of the DGAFMS.
Okay. We'll go to the next session. We'll discuss this thing in lunch.
We are going beyond time. We are already half an hour late. So please wait.
Sorry for taking time more than anyone, but you know there's a problem with old people. They want audience. So I have the opportunity. Thank you very much
Next
for
speaker,
wonderful talk.
Dr. Arpita.
Mike me.
Dr. Gurmohan Singh sir also
Sir, we have to start
very
the talk.
nicely.
Can we start the next talk, sir, please? Already late.
Next session.
Emergencies, managing emergencies.
So the problem is they get panic when the medical officer makes them unfit.
That is where all the panic comes. But then we go to the specialist. When they go to the specialist, all these cases are clear. That's when we find out the situation and we couldn't and that's why we write prescription. I mean, see the problem, that's what I was telling you.
Targeted therapy in vitiligo, and the same can be used in various other dermatological conditions also. This is the outline of my talk. I don't have any conflict of interest, but this is the most in the examer laser. So, examer laser, we all know, this is a excited dimer. So, basically, this is a noble gas of and halide which repel each other, and the most commonly used cell is xenon chloride. So that gives rise to 309 nanometer. So we all know the advantages are a lower UV dose exposure is required, a shorter course of therapy is required theoretically, and being a directed therapy, so it can be used for distinct sites which are not responding to the conventional treatment and all, and it can be used for difficult to reach sites. So there is a difference between examer lamp and light. So light is non-coherent monochromatic light source is source of 304 to 308 nanometer. So this is how the examer light is produced. So there is a reflector and there is a translucent reflector is there, and the xenon chloride gas is filled inside. So it goes on to excited state and gives rise to this emission of this light. So mechanism similar to the phototherapy, there is absorption of 308 nanometer light by the keratinocytes and T that induces the DNA damage. It causes reduction in T lymphocytes, so that gives the effect in most of the inflammatory conditions, and keratinocyte proliferation is also reduced. There is upregulation of P53 tumor suppressor pathway and downregulation of BCL2 proto-oncogene, leading to cell cycle arrest and apoptosis. So in inflammatory conditions, various pathogenesis has been described in various reports. So it penetrates the epidermal cells and fibroblasts to induce apoptosis. It can also induce DNA breakage and upregulation of suppressor genes and decreases the proliferation. In psoriasis, it upregulates the tumor suppressor pathway. There is arrest of the cell cycle and prevents keratinocyte proliferation. In pigmentation, various pigmentary disorders, it induces hypertrophy and hyperplasia of melanocytes, thus increases the overall melanin content. It also stimulates hair follicle melanocytes to migrate to the epidermis and promote repigmentation. In pruritic disorders, it inhibits mast cell degranulation to improve the itch sensation. It can induce regulatory T cells to switch into antigen presenting cells phenotype from stimulatory to regulatory one, which may lead to long-term stabilization of the disease after treatment. Coming to the usage, we all know it can be used only for limited disease area when there is the patient is having a disease in a very limited area, because it has to be used in 2 to 3 times a week, similar to the phototherapy. So it can be difficult. So treating the patients can be difficult because the patients, they have to go to the school, they have to miss their work, and as sir already was telling, there can be a chance of losing the income. So there should be 48 hours gap between the doses. The spot diameter varies from, there are various, as we can see, various spot sizes can be chosen according to the lesion size. So spot diameter varies from 14 to 13 millimeter. The device is handheld, that gives advantage when children are the patients, because they are not afraid, because the person who is giving the therapy is there. And it is FDA approved for psoriasis, vitiligo, atopic dermatitis and leukoderma.
So the advantages we have already discussed. It penetrates deeper as compared to narrowband UVB. Higher irradiance is there. That is why maybe the dosage required is less for the effect, and it is benefit. The main advantage is it can be used for difficult to reach sites because it is handheld and easy to administer. So, and another thing is site specific dosing can be used. So this is the list of various diseases where it has already been used and it has been reported. So one by one we will go through. So treated vitiligo, this can be used. So the rate and speed of repigmentation is highly associated with the site and duration of the disease, like any other therapy we use in vitiligo. The face and neck areas which are to respond. Joint and extremities, they are difficult to respond to any kind of therapy. So shorter disease course, more promising is the treatment result. And childhood disease, it can be used safely. So this is a treatment that is usually available along with the machine. We have to make sure that there is, as sir was stating, there should be no erythema or very minimal erythema should be there between the two sides. If persistent erythema, we should skip the dose. Then, so it has, there have been various reports. It significantly reduces the vitiligo severity and there is higher repigmentation as compared to the other safer phototherapy we had, narrowband, that is narrowband UVB. Even it can, it has been reported to have better improvement in long-term treatment as compared to topical calcineurin inhibitors. So these we have discussed. It can be used as part of the combination therapy because if we are, if someone is not responding to any of the therapies, we can combine the therapies. It has also been used in psoriasis. So there are two vitiligo cases. The lesions should be limited and difficult to access areas should be chosen. Basically, it has been reported to be cases of psoriasis vulgaris, scalp, and palmoplantar pustulosis, and so this has been reported to have lower cumulative dose as compared to narrowband UVB again, and around 3/4 of the patients they had responded in one of the studies with 6.2 treatment sessions. So that is very promising. We have to use ourselves to see the real effect. And similar responses has also been in other cases. So in one of the reports, they had reported that the children, they required more number of treatment sessions as compared to adults in case of psoriasis. And as we were discussing in the morning, alopecia areata, this can be one of the treatment options. But in one of our patients, we had to go back to, after around 3 months of sessions, we had to go back to our age-old tricot, Kenacot. Similar to vitiligo, the maximum effect is seen in the head and neck area, that is the scalp lesions. Total effect is seen in lesions and extremities. Then this has also been approved for atopic dermatitis. So localized forms like pityriasis alba, this can be used. This has been shown to improve the clinical scores and pruritus in various studies. And another, while I was preparing this, another good thing I came to, in the literature it was there that this has been reported to be effective in prurigo, where we usually find it difficult. We have to inject Kenacot, otherwise nothing else. But this has been reported to be as effective as clobetasol in case of prurigo. Then localized early stages of mycosis fungoides, this has been used. Two reports or case series have been published. So we have this machine in our department. So as we can see, this patient, she got almost 40 to 50% improvement, but
Again, this was in the face area, and she had also been using other modalities of treatment like topical calcineurin inhibitors. Another patient. So here we can see the side effects of hyperpigmentation was there. There was little bit of improvement the patient, but she was happy with the another in a child who had segmental vitiligo, the genital area was involved, and we can see there is some degree of improvement in the child. This patient, she had lip vitiligo. We were discussing lip vitiligo is very difficult. So after around 4 to 5 months of therapy, she did not have any improvement. So later we had the ablative mode of CO2. After one session, she got the repigmentation around days later. So side effects we saw, there can be erythema similar to the other modes of phototherapy, blistering, hyperpigmentation we saw. And pruritus can be there, even scaling can be there, because when the erythema will subside, it will subside with scaling. So to conclude, so the efficacy is not much, I will like to vary here, not much efficacious, it is average. If you compare the cost or the effort the patient has to put in for getting the sessions and the effects that it gets, so it is not much impressive, but it has definitely got additional benefit, and it is one of the, it is an additional tool in our hand, which we can use for treating the various documents.
Thank you for all the chairpersons and speakers for the wonderful session. I request Dr. Dinesh Mathur sir to kindly felicitate our faculties. We'll move on to the next session. For that, I request Dr. D.G. Sapal sir and Dr. Indrani Mohanty ma'am to kindly share the session.
So I was losing my mind. Why? Because we've been magnanimous in treating somebody with a condition which requires treatment. So we cannot realize what this. पूरी बातें करना बड़ा आसान है. Cannot lose the man. Cannot lose the man. सरकारी दफ्तर में आर्मी हो गया क्या करें? When the army cannot lose the man, he is fine treating. क्या करें? उसको तनख्वाह नहीं करते. Getting the treatment, avoiding going to Iraq, going to Asia, because he's seeking the treatment. There's so many issues in patients, any condition. So I say, same thing. Any condition which requires long-term treatment, he will avoid. हमें बोलना आसान है यार, छोटा सा मिट्टी को क्या प्रॉब्लम है? It's not that. Oh,
हमारा तो हो गया ना।
फोटो भी ले लिया। लेक्चर तो देना है।
लेक्चर तो हो गया मेरा।
और ये आप ध्यान से वीडियो अच्छो।
Hello. I think our next session is indigenous dermatology, and it is none other than Dr. Datta, R.N. Datta, who is very well known to everybody. I think without wasting time, because already we are late. So, sir, can you go ahead?
Good afternoon, everybody. The topic of my presentation is slightly different. After being the HOD at PG Hospital, that is IPG and Aesthetica Hospital in Kolkata, when I retired, I thought that I should do something Jara Hatke, because we all talk of modern medicine. There is a huge storage of Indian or indigenous medicine which we are not taught, which we do not know, and my present, you may say, passion is to let people know that there is many things which is around you. Just because you do not know, you go to the doctor for the first instance. So those things I am trying to, in every different presentation, I say something different. Today it will be an overview of haldi and sodi vaika. You all know haldi. You know all cooking soda, so meetha soda, which is being called. So these are two things. Nature itself is the best physician, and who has written it? Hippocrates. Deep look into the nature, and then you will understand everything better. Who has written it? Albert Einstein. The problem with us is that until it is endorsed by the West, we do not take it. We are not confident about our indigenous materials, the science it had. Of course, at present, not a lot of work is being done. That is why we do not understand what is going on. You can see this turmeric. For ages, our mother used to use it in the cooking. Why? There has to be some reason. And I'll show you the reasons. And that was the principal spice. It is used in religious ceremonies and it's called Indian saffron. I'm not going into the details. What I am trying to show is this: whatever I am telling, none of them are my words. They are endorsed by the West. They are endorsed by the scientific fraternity. And that is why I have kept these. Others have shut out. So it helps in digestive disorders. You can see the blue, that is the references, and the yellow is the benefits. Digestive disorder, liver and gallbladder disorder, anti-inflammatory, antimicrobial, carminative. It is inflammatory bowel syndrome. It works there also, but we do not know. We use salazopyrone and what not. And colon cancer, there also it helps. And for arthritis also. I remember when the when we get sprain, we go home, mother used to give haldi and chuna, eat it and apply it. And next day or the second day we are okay, we again go for playing. And we could play football. So that is the strength of our indigenous medicine, which we now refuse to learn. So it inhibits lipid peroxidation. You can see in the blue the references. Found to inhibit microsomal activation dependent mutagenicity. Found to inhibit activation of human dendritic cell in response to inflammatory cytokines. It is used as a Chinese medicine, Unani medicine, Ayurveda. You go to any Southeast Asia country and you see haldi is being used. So this presentation aims to provide an overview of scientific evidences supporting the diverse therapeutic potential of turmeric. That's all. So turmeric contains a variety of bioactive compounds. It has antioxidant properties. It neutralizes free radicals, prevents oxidative stress, and enhances the activity of antioxidant enzymes and scavenge reactive oxygen species. You can see the references down. It has anti-inflammatory effects. inhibits the activity of inflammatory enzyme and reduces the production of pro-inflammatory cytokines. And you can see number of references. It interferes with this anti-cancer effect it has. What happens, curcumin may have anti-cancer properties inhibiting the growth and proliferation of cancer cells. It interferes with various molecular pathways involved in cancer and in the development and progression of cancer cells. Neuroprotective, it crosses the blood-brain barrier and may have a role in preventing neurodegenerative diseases. So if you keep on taking haldi, your neural degeneration may slow down, as it is written by those which is references given downstairs. Cardioprotective benefits. About the safety of curcumin, it is considered safe when consumed as a spice in culinary amounts. The small amounts we take, and that is very safe. If you take more than 8 grams a day, then only it may have some problem, otherwise there is no problem as such. And 8 grams is probably 2 tablespoons. Curcumin and skin, potential benefits of the skin due to anti-inflammatory, antioxidant, antimicrobial properties. Curcumin promotes wound healing by modulating inflammatory response and enhancing collagen kinesis. When I was a child, I saw this, so they take the testis out, they cut it. They usually done by a local people. They take out the testis and apply only haldi, that's all. And that goat gets cured within no time. They didn't use any antibiotic, nothing. So such is the effect of haldi, which we may or may not know. It has antimicrobial activity against various bacteria, fungi and viruses. No known interaction of drugs with turmeric has been reported. Then can we as doctors incorporate haldi in our prescription or as a co-prescription or an advice to the people? Let's accept it in some way or the other. Let's promote this quality to your patient, your friends and everybody. This is a video I want to show. Just 1 minute. So, why is haldi used as sorry. There's a function about haldi. अरे इसको कैसा बंद करना है? हाँ. Haldi, as I told you, it has antiseptic property, antivirus, antifungal. So when two people meet, before that, if they sanitize, not only water, you can't use Dettol. Haldi is probably one of the best things, and it gives glow and shine to the skin also. So that is why in any of the states of India, you see haldi as a rasam before marriage. So modern medicine has begun to recognize its importance, as indicated by over 3,000 publications dealing with turmeric. And that came out in last 25 years or 30 years only, not more than that. Although modern medicine has been routinely used in treatment of various diseases, it is only less than 100 years old. But traditional medicine, in comparison, has served mankind thousands of years, and most of these are quite safe and effective. Though the scientific basis of this traditional medicine is less well understood. We could have understood it had our this civilization, the people who don't have burned the library of Nalanda, where it took 6 months to get burned. Millions of papers were there, which told about the scientific things. And in Nalanda, people all over the world used to come there and study. There's a temple in Japan where it is written in Japanese that here contains the earth of India, of Bharatvarsh. So the respect India used to get at that time, that is there. So we had that size, only thing it is lost. Why was it lost? Because we were not bold enough to counteract those invaders who have destroyed everything. Nature helps. And that is why I think we should go back to nature also. I'm not telling that you throw these out, because these are all scientific or Western medicine. We should use it, but we should along with that think about indigenous medicine. Baking soda. In 1927, the Journal of Chemical Education, they said that keeping an alkaline balance of the body through regulated dose of sodium bicarb is good. Sodium bicarb is being used all over the place. Eno, gasofast, all the other things, what do they use? They use soda. That is the main thing. I'm not going into deep because there is lack of time. You have heard of alkali mixture or alkasol, most of the people. The old doctors, they go to the patient, if the patient had fever, they used to give alkaline mixture. There's bottles with marked dosage over there, so you take that much in a spoon or just drag it off. So it used to help, but somehow it got eradicated. Still, this alcohol is present in the market. It is a systemic alkalizer. When the body gets acidic, this alkalizer helps. Baking soda as an abrasive in toothpaste. Did you all know? I don't know. But look at this. Oh, sorry. I don't know which one to take. Abrasive toothpaste. Now, come to the next one. You see, this is the amount of percentage of your sodium bicarb. This 100% is the parameter, and you can see how much sodium bicarb these big companies in their toothpaste they have. So it can kill cancer cell also. And the Western world scientifically are using it. You can see the tumor type, the model, and administered of NaCHOH over here. So it is being used to treat cancer. So you can understand the value of sodium bicarb, which is at home, but we don't know how to use it. Actually, toxicity. Not only evidences of harmful effect of using sodium bicarbonate in general is not found, but also many benefits of using this compound in therapeutic doses have been reported. So you can understand the effect of sodium bicarb. Moreover, it is used in relief of irritated, itchy skin. It is a natural deodorant, natural mouthwash. It is exfoliating face wash. It is mildly abrasive. You can use that. I am not telling you take soda and just rub it in the face. That will be wrong. A consultation will increase. But you see in other literature and you can find out. Nature helps. Can we use this along with our prescription or co-prescription or simple advice to the people we know? We have chosen this profession for the benefit of others and for our satisfaction. Happiness is the ultimate aim of your life. So money is important, but the priority is happiness rather than money. The choice is yours. So please spread this message of indigenous medicine for the benefit of yourself and the benefit of mankind. And thank you.
Thank you.
Time less.
Thank you. One question is allowed, and that should be a short one.
Yeah, short question and one comment. I just wanted to know, this curcumin plant is a red plant. How does it convert to yellow thing? And second thing, that I learnt this message that soda bicarb is anti-cancer. That is why you should always mix soda in the drink, not water.
In what? Drink. Right. That is why he is so fit and fine at this age. Chalo, we all follow your advice.
Thank you, Sudhani ma'am. Thank you, sir, for the nice presentation.
From the next session on critical management in dermatology, I request Dr. D.G. Sarpal sir and Dr. K. Lokendra sir to kindly chair the session.
Deepak.
Sir, kindly, Dr. D.G. Sarpal sir, kindly sit.
I think our next subject is emergency dermatosurgery and its complications. Speaker is Dr. Manak Chatterjee. Again, no introduction is necessary.
I request S.K. Singh sir to kindly give memento to our faculty.
Yeah, because up to now we have seen the medical emergencies, but he is going to elaborate or he is going to enlighten on what are the problems of dermatosurgery, especially when you are new in practice and probably you are not careful in practice. Please go ahead.
Good morning, good afternoon, ladies and gentlemen. As he sort of sorts it out, we're going to talk about emergencies and dermatosurgery. So what's important here is emergencies in general in surgical dermatology are generally less common. We don't have exact data, and they are very rarely irreversible. So that's something which is good for us. So there are primarily three issues which are important as far as emergencies in dermatosurgery is concerned. One, certain patient factors. Now, what are these patient factors? Allergies, medications in patients, any previous surgical complications, family history of certain disorders, patient psyche is important. Of course, systemic illnesses are important, and of course, patient education is also important. So these are certain patient factors that are important. Certain provider or personnel factors, your emergency plan. Okay. So your emergency plan. How good is your emergency plan? What are the types of procedure that you're doing? What are the pre-assigned roles? For example, if you have an anaphylaxis, every member of the team has to have an assigned role which is given before. That means who is going to call the emergency medical team, who is going to give the adrenaline, who is going to get the oxygen, who is going to do what part, who is going to do CPR. Everything should be pre-assigned in your team before you actually are faced with a problem, and these should be repeatedly rehearsed. So that is very, very important. And of course, checks on your drugs, checks on your protocols. These are good to do. It's something which I have done. So we have a drill running. A minor drill every month. A major
drill every 3 months. And of course, available with you or not. Fire extinguishers, that's also important, because when you're doing procedures such as lasers, when you're doing electrosurgical procedures, fire safety is important. So this is, for young people, this is your ABCDE. So A stands for certain things, anaphylaxis very importantly, lignocaine allergy, pseudo-allergy, primarily vasovagal, and of course last, which is toxicities. Brain, so strokes and status epilepticus, cardiac, so basically arrhythmias, coronary syndromes, hypertensive crisis, hypotension, hematomas, hemorrhage, etc. Certain diverse, such as hyperventilation, accidental injuries, device related, and I mentioned about fire. There was also, of course, laser eye injuries, and of course, embolism of all three types. Of course, air embolism, I'll just mention very briefly. So, air embolism primarily in those with the patent foramen ovales, so those are groups of people who are much more prone to air embolisms, but it's not very common. There's one procedure where it can happen, and that is foam sclerotherapy. So that is one place. So if you have a patient with a patent foramen ovale, avoid foam or use a higher concentration, less air in the foam. Venous thromboembolisms are not very common in dermatologic surgeries, except if you're doing Mohs. So that is one place where VTEs are common because they are long duration surgeries. And of course, filler embolism, I'm not going to talk, people keep discussing fillers. So anaphylaxis, remember, latex is a cause of anaphylaxis, so that's one thing which is important. And of course, pre-operative drugs. So for example, I use pre-operative antibiotics, single dose. So that is one place if you have a patient with a sensitivity. Now these are certain, just see the things in bold. So these are certain risk factors for anaphylaxis. So infants, adolescents, advanced age, pregnants, those with mastocytosis, those on beta blockers. Now I'm going to tell you two things on those with beta blockers. I'm going to kill the second thing as well. So let's say if you have a patient on propranolol, remember one thing, one is a increased risk of anaphylaxis. The second thing, which is not mentioned here, is a hypertensive crisis. So remember, people who are on propranolol and who've been given adrenaline, lignocaine, alpha adrenergic activity. Okay, so unopposed alpha adrenergic activity. So if you have a patient where you require more anesthetic lignocaine with adrenaline and the patient is on a beta blocker, be really careful. Certain other cofactors such as exercise, infection, fever, ethanol, alcohol, NSAIDs, so a disadvantage with alcohol. And perimenstrual. So these are certain risk factors and cofactors in anaphylaxis which sometimes we do not sort of remember. I'm not going to talk about these. The diagnosis is pretty simple. All of you would be able to diagnose anaphylaxis. But yes, remember the treatment is pretty standard, but a lot of times we panic. And here probably if you have a patient resting, then these are certain things which we must sort of remember. At least one person who is BLS or ACLS qualified in your setup always helps. So this is something this is a course which is run pretty regularly. It's anesthetists who run it. So remember, our national helpline now is established. So that is 112. So if you have the facility of a defibrillator monitor, sorry, we don't have the facilities of a defibrillator monitor, then of course you're going to go left, the one on the left side. But if you have a cardiac monitor available to you, it's always good to decide whether you have a shockable or whether you have a non-shockable. So remember, whether your cardiac issue is shockable or non-shockable is very important. So if you have a VTAC or a VFib, then of course that's shockable. If you have a regular asystole or an electromechanical dissociation, that is non-shockable. So non-shockable cases use adrenaline. If it's shockable, if it's a VTAC or a VFib, you've got it on the monitor,
do a defibrillation, do an external cardiac defibrillation. So this differentiation, if you have, so if you don't have, for example, a monitor, a defibrillator, a monitor, this becomes a little difficult, and that can actually be taken as lack of adequate care. So decision whether you have a shockable or a non-shockable cause of a cardiac event becomes important. So lignocaine allergy. Remember, we have the parabens. Remember, what happens is that your ester-based anesthetics, which we don't use anymore, see, they break down to PABA, and they have an allergic potential. But remember one thing: parabens, which are there as preservatives to amides, which are not esters, so these parabens can also convert to PABA and have an allergic potential. So therefore, this PABA-induced allergic potential can be there in both. Svetlina's gone to sleep. Okay. so sodium bisulfite. This is an antioxidant used in adrenaline. So this is another agent which can cause an allergic reaction. Just remember these things. So we've always thought of the conversion body weight if you've got local adrenaline, local anesthetic alone, and 7 milligram per kg body weight if you've got with adrenaline. Remember, it does not work in children, and I have faced it. And when I was in Jabalpur, and when this was not even known to medical science, that children tolerate local anesthetics much lesser than adults. So the quantity which you can give is much lower, just 2 milligram per kg body weight and 4.5 with adrenaline. So this is one thing I remember I was giving, in a keloid, I was giving a local anesthetic, and at that time we didn't know this. Medical science was not aware, and this is of course almost a couple of decades back, where this child had a problem, went into status actually. That's because the amount they are able to tolerate. Drugs such as cyclosporin, children tolerate much better than adults. But here you have a drug which children don't tolerate as well. So just remember, the dosage for children are lower. Next is bupivacaine. When you're doing hair transplants, remember this is one agent that you use. Here you see CNS features, that subcamoral numbness, etc. The CNS features with lignocaine, toxicity, they guide us. But with bupivacaine, it may not be there. So these people can go straight away into asystole without these CNS, warning signs. So that is one thing we must remember. And here, of course, with bupivacaine, lignocaine is not a great drug. If you want to reverse a cardiac event, here bretylium is a better drug. So this is just one thing which you just must keep in the back of your mind. Vasovagal, just remember certain predispositions. That is important. So remember, young women who haven't slept too well. So ask your patient whether you've slept well, who are fasting, if the OT is too warm, they are much more prone to vasovagal attacks. And of course, standing we all know. So these are certain common things which make them a little more prone to vasovagal. Remember, the difference between vasovagal and anaphylaxis is anaphylaxis hot, warm, red skin. Okay? So this is sort of the table. So a cold, clammy, with diaphoresis. So that suggests pale. So these all suggest vasovagal. So pale, cold, clammy, vasovagal. Red, hot, it is anaphylaxis. So that just keep that at the back of your mind. You will always be right. One of the things which really prevents it, if you are having a patient who is telling you, remember the vasovagal, you get an idea. The patient will give you markers. Okay, the patient tell you, I'm not feeling too good. Tell them to do an isometric. A lot of times it reverses it. So just ask them to, do something like this, all these, postures which I have shown you. So that really helps to prevent a vasovagal, okay? And of course, a little bit of anxiolytic before surgery, that also prevents it. But the isometric, nothing like it. Works really, really well, okay?
Treatment, I don't think I need to tell you, we all know about atropine, so it's not something which we need to sort of discuss, but yes, a little more frequently. Hypotension. So remember one thing that, so in most cases of hypotension, you will be able to do well with hydration. But sometimes prolonged hypotension, steroids work quite well, an injection steroid, and this works in hypotension of varying etiologies. So if you have a patient who continues to remain hypotensive, just give him a shot. Just give him a hydrocortisone shot. It will work, or it will work under most circumstances. So that's the last thing which I have written. So that prevents a prolongation of hypotensive event. We all know hypotension can be of two kinds, etc. Orthostatic vasovagal. That I'm not very interested in telling you. But the thing of using steroids, hypertensive crisis. Now this is again something which I have faced. Perils of doing too much surgery. So this will occur in people who are hypertensive already. Okay. And an hypertensive urgency is much more common than an emergency. Emergency basically includes organ damage. But what is really important in these cases is to hold back surgery, give an anxiolytic and not an antihypertensive. Okay? So here an anxiolytic is much better in a hypertensive urgency as compared to an antihypertensive. Okay? Now, which are the people who are a little more prone to arrhythmias? So remember, I told you about lignocaine adrenaline, people with tuberous sclerosis. Okay? Rituximab, people on regular rituximab. Suppose you have a patient of pemphigus who is on rituximab and you are doing a procedure. Be careful, these people are a little more prone to arrhythmias. Sarcoids, lupus, systemic sclerosis. So just keep these things in the back of your mind. The rest you know. Coronary syndrome, just remember the last thing which I have written. You might have patients who are on sildenafil and tadalafil. Okay. Now remember here, please do not use nitrates. So that is the important thing. And of course, the blood pressure issue we already know very well. Right ventricular infarct you already know. But if you have a patient who is on a phosphodiesterase type 5 inhibitor, conditions with erectile dysfunction, one very interesting aside, of course, other than this talk, and that is I have been to some very senior dermatologists who have come to me from Bangladesh. Just for experience with me last week. So they said a fourth of their patients transconjunctival blepharospasm procedures for this is a before and after another. So when you're doing a transconjunctival bleph, you are prone to having a patient with a retrobulbar hematoma. So anybody who does this must be careful. You must know just one procedure, because CT will pick it up, but one procedure, and that is a lateral canthotomy. So this is one thing which you must learn if you're doing this. In fact, my hospital ophthalmologist made me learn this. Okay, this is something, he is a rheumatologist of our hospital, and I was doing a filler in the tear trough. So what happened was that, so the infraorbital vein was going up and down. So here, at that margin, I actually hit the infraorbital vein. So sometimes you can have slightly disordered anatomies. So you must understand that in these cases, you must have your plan ready, your alternative plan ready with you to ensure. So nothing is required. Compression does the job. Okay, so that is the important thing here. So I'm not going to talk about Hyalase-related vascular occlusions. So just one thing, and that is when you're preparing, hyaluronic acid-related vascular occlusions. Just one thing, if you're preparing your hyaluronidase to inject, remember, inject it in a lower volume. So remember, do not use a higher volume. That means please don't do anything more than about 2 ml per 1500 units. What's going to happen is, when you inject, if you inject a higher volume, it itself will cause a compressive vascular occlusion. So inject your hyaluronidase in a smaller volume. So that is the only sort of tip for you. This is something which can happen, not my case, it's a published case. So occasionally if you're doing sclerotherapy, if there is an aberrant vascular connection. So remember, you must tell patients, this is something which I tell patients, look, we look after the regular standard anatomy. Sometimes some people might have a little disordered anatomy which might lead to an issue. We are capable of dealing with it, but remember, it can happen very occasionally. Yes, this is one very important thing about status epilepticus. Of course, the patients who are at risk, one is Sturge-Weber, NF, lupus, but the important thing is this. Now, this is something which I find a lot of us are. So remember, if the patient is seizing, do not turn the patient to a side, the patient is not breathing. Just remember that. If he is seizing, you don't need to pull out the mouth. He is not going to breathe at that time. He is going to breathe once he stops seizing. So once he stops seizing, turn him to the side. So don't do it when he is seizing because you want to break his bones. So that is something which, we always in a panic, he is seizing, we try to, forcibly open the mouth, you do a suctional oropharynx which causes a spasm, and he is thereafter will not be able to breathe. So just remember, he is seizing, let him seize. Once he finishes seizing, turn him to the side. Turn him to the side. Once you've turned him to the side, that is the time you open his mouth. Don't do it when he is seizing. And this is something which a lot of us do. Hyperventilation. Now, if a person is hyperventilating, read the last line. You stand in front of him, guide his breathing. Okay? Just tell him, do abdominal breathing, hold his chest. Tell him this should not move. Make him breathe from the abdomen. It's the best way to address hyperventilation. Remember, it's something which a lot of us nerve injury, I will probably skip. It's not very common. You can have certain branches getting involved. The temporal, when you're doing your subcisions.
Manas.
We are done. I think we'll finish. Thank you, ladies and gentlemen.
Thank you very much, Dr. Manas. You have given a very nice talk. Fortunately, we don't, as for me, I don't experience these emergencies very frequently, but if it happens, it's very serious. Questions from the others, please.
Dr. Manas, whatever you told, that we need the full emergency setup. But for our young dermatosurgeons who have a minor OT, they don't have much of those facilities available. Actually, the basic line things that they should manage, like vasovagal or lignocaine toxicity or something, because the setup like this in your army setup, everything might be available. But very often, the most of dermatosurgeons, these facilities are not available at all. So give them the usual tips, which is more important than that.
No, so I thought I told you about the important thing, how to prevent a vasovagal. We discussed that. What you need to understand about children being given local anesthetics, that I addressed. So I generally addressed most of the common things. I don't think I missed out any of the common things. Yes, there are certain things which time doesn't permit, so which I will not talk about. But if you remember whatever I have said, just keep all these things in your mind, you would be able to address most of the things. I tried to keep myself, except for the retrovalvular hematoma, that was just an aside. Other than that, I kept to things which probably we miss out. Probably, I'm telling you, I have seen this umpteen times, even among doctors and specialists. Patient is seizing, he's turning to the side. He's not breathing then. He's going to take that breath after he seizes. So that's why I just just telling you certain things which I felt was important.
How common this lignocaine hypersensitivity you are seeing?
So lignocaine hypersensitivity is not very common. It's not really at all common. Remember one thing, sir. It is the basic issue is that there are some lignocaine itself is not a common cause. In fact, it's actually documented cases of lignocaine in itself causing an allergic reaction are vanishingly rare. It is usually the papa. it is usually the parabens which convert to PABA, the parabens which are preservative. So here, Xylocard is a good idea. So you can use preservative-free lignocaine. If you're using preservative-free lignocaine like Xylocards, if you have a patient who's told you that we could reach that slide. So if you have a situation where the patient tells you that I have got lignocaine allergy, then go to Xylocard, or that sort of takes care of it quite well.
Dr. Manas, thank you very much. Wonderful information. And I would like to say something that always, as you say, he said, if you have not done medical term or they have not worked in the medical department, you'll find it very difficult. So always when you are doing surgery, see that somebody in your neighbor or somebody has to be with you. For example, we have surgical unit, but we have got a cardiologist next room. So anything happen, always we can take the help of that. Secondly, emergency is not this emergency. I'll tell you, yesterday I was just coming, I landed at the airport. One of the girls, she had some lesions on the nipple. Biopsy was done, and they phoned at about 8:15. I'm vomiting, I'm feeling cold. And I do not know her father, he got panicked. Doctor, what is happening? Because the biopsy, this is happening. So, these are also emergency. I said, don't worry, this cannot happen with the biopsy. After biopsy, anybody gets this after 3-4 hours? Less likely. Then again, after 2 hours, same thing phone came, yesterday night phone came. Then my wife was telling, ask them, she must have taken food outside. And she must be having some food poisoning. Baba So, we have to be prepared for it. We gave her panty and she was alright. So, the message is, you have to be attentive. Anybody gets some problem, you have to be attentive. Because you should not avoid, that's called the negligence. So, usually we do not attend phone, but because this poor patient, see, from them it was emergency, always try to attend, otherwise it will amount to the negligence.
Thank you, sir. I thank chairpersons and speakers for the session.
Thank you, Dr. Datta. Thank you for giving this session. Thank you very
I
much.
request Dr. Midula Paul ma'am to kindly felicitate our faculty.
There's an announcement for the gift. You go to the MSN counter and they will give you the gift. And the lunch is on this side. Please, after this session, I think it's finished, please join for lunch. The counter for gift is MSN counter. And in the evening there is a gala dinner. Please join us there also after the session is over. And there will be inaugural session will be from around